can't hear Bashir. Everybody else can, or
I can hear.
Bashir was
We
soft.
all can hear you.
Our opening batsman is Dr. Syed today.
Yeah.
Yes. So, incidentally, Syed, you're the Aisa Kanaiya today.
Exactly.
Because he's surrounded. ये तो एकदम Kodak moment है. Syed, you're surrounded by all females. Sorry. Amal, you can start. Please go ahead.
Okay, ma'am. Okay, ma'am. Good evening, respected chairpersons, eminent delegates, and faculty. Myself, Dr. Amal Shahryar. I'm senior resident in the Department of Endocrinology, PGI Chandigarh, and I feel honored to welcome you all on the behalf of Endocrine Society of India to the second session of this webinar. The theme of this webinar is diabetes and Ramadan. And we are privileged to have two eminent faculties with us, Dr. Neelavani ma'am and Dr. Motisi Rai Chaudhary ma'am with us today.
Bashir, slides, please. Bashir, CV slides. We all know both of them, but Amal is still going to do the formalities of the introduction until we get the slides up there. I'm utilizing this technical time to again extend a warm welcome to each and every one of you who's logged in. We had a very, very interactive session last about 2 weeks back, and we're again looking forward to an equally interactive session. So please, whatever questions you have, whatever you need to ask us, everything, please feel welcome to send it across to us, and we'll try our best to cover all your queries in the next few hours that we have to our disposal. I think Bashir is still having some
Technical.
glitch over there. Amal, you have the slides
Yes, ma'am, I have.
with you. Can you say it from this bit up, please, if you don't mind? Thank you. You can introduce both ma'ams from the slides which you have.
Okay, ma'am. So, I feel honored and privileged to introduce Neelavani ma'am. Ma'am is professor and head department of endocrinology, Usmania Medical College and Hospital, Hyderabad, and ma'am is member of the Scientific Advisory Committee, ICMR Hyderabad, as well as regional faculty, PHFI faculty in IMA CGP Certified Diabetes Fellowship course. Ma'am is investigator in several drug trials and member of RSSDI, ESI, ISBMR, ITS, and American Endocrine Society. Ma'am has publications in various national and international journals, and ma'am has authored chapter in various books. Ma'am has keen interest in promoting public health education and awareness on diabetes and bone health. I feel honored to welcome Dr. Motishi ma'am also. Ma'am is professor and in division of endocrinology, ICH Kolkata. Ma'am is consultant endocrinologist in Narayana Health Kolkata. Ma'am has around 23 publications in peer-reviewed journals and has contributed chapters in several books. And ma'am is invited speaker at various national and international conferences. Ma'am is past honorary general secretary, Endocrine Society of Bengal, as well as vice chairperson, RSSDI West Bengal chapter. So, without any further delay, I would request ma'am to please address the gathering.
Ma'am, we would request both Neelavani ma'am and Dr. Rai Chaudhary ma'am to please set the context, and then we will request Dr. Syed to please take it forward.
Okay.
Would you like to address Dr. Rai Chaudhary?
Yeah.
Yeah.
Okay. Yeah,
Yeah.
it's a great pleasure to be a part of today's meet with Ramadan festivities around the corner, and I think this was very much needed, especially on part of the treating physicians. I mean, what to do, what not to do, and how best to guide their patients. Now, the first topic I think is going to be a very interesting one, whether the recommendations for type 1 diabetes are changing. I think this is very relevant in the context of availability of newer insulins, availability of CGM facilities, SMBG, and also, advanced insulin delivery systems. So, and I think it's time we moved away, from the earlier guidelines, which were set when maybe we went for twice daily premixed insulins, and there was not much support system, not much of monitoring. So to do the honors, we have with us Dr. Syed Mohammad Razi, and he is going to highlight this topic. So over to you, Dr. Razi.
Thank you. Thank you for those kind words. I would be presenting my slides on my own, and I think my screen is visible.
Sayed, if you can just for 1 minute, if Amal can just introduce you and then you can start your presentation, please.
Sure, ma'am.
Yeah,
So,
thanks.
I
Amal,
am
please
just
go ahead.
stopping the share.
And till then you can upload your slides
Yeah,
and Amal will
sure.
continue the introduction. There's been
Sure,
some
ma'am.
technical glitch, so
Sure, ma'am.
we are unable to upload them directly from the backend team. Amal is just doing an introduction and then you can please start your presentation.
Yeah, ma'am.
Amal, please go ahead.
Yes, ma'am. I would like to introduce Dr. Syed Mohammad Razi, sir. Sir is consultant endocrinologist, Sri Sai Super Specialty Hospital in Moradabad and Diabetes and Hormone Care Clinic, Moradabad. Sir was ex-registrar in the Department of Endocrinology, LLRM Meerut, ex-registrar at Rajiv Gandhi Center, AMU Aligarh, and ex-assistant professor, Faculty of Medicine, JNMC, AMU Aligarh. And sir is a gold medalist for securing highest marks in DM endocrinology as well as for securing distinction and selected for type 1 diabetes fellow training program by Endocrine Society as well as selected as an international medical observer in Cleveland Clinic, Ohio. Sir had more than 30 research publications in various national and international journals and has delivered lectures in many regional and national field meetings in the field of diabetes, thyroid, and reproductive endocrinology. So over to you, sir.
Thank you for the introduction. And I would be having my slides. I think the slides are visible now, and hopefully they are in presentation mode now. My slides.
They are
Can you see
visible.
them?
Yeah, that's great. Thanks.
A very warm good evening to the August House of Endocrine Society of India, and I am very much honored that Endocrine Society has given me such a platform to introduce the topic. Type 1 diabetes, are recommendations changing? As ma'ams have really pointed out that in initial days when insulin delivery system and CGMS devices were not so strongly available across the country, we had a habit that type 1 diabetes and fasting, they are taboo topics, and any patient who is coming from any background, if he's asking for fasting, he's a type 1, he should not. The guidelines were so till 2017, and then there was a change. So I would be in the subsequent topics. These are the contents of the talks. Firstly, the introduction, then epidemiology of type 1, then type 1 diabetes and Ramadan fasting, potential complications and safety, how we can address, old school recommendations, newer recommendations, pre-fasting diabetes nutrition, blood glucose monitoring during fasting, and finally, the insulin regimens during Ramadan, along with the devices. So, introduction. Type 1 diabetes, as we all know, is an autoimmune condition that occurs as a result of destruction of beta cells producing insulin in islets of Langerhans, usually leading to endogenous insulin deficiency in severe form. Type 1 diabetes represents approximately 5 to 10% of all diabetes, and the diagnosis classically occurs in children, but can also occur in adulthood. So epidemiology, the incidence of type 1 diabetes is rising across the world globally. And globally in 2020, an estimate of 8.7 million people were living with type 1 diabetes across the globe. And adult onset type 1 diabetes is more prevalent in men than women. Half of the new cases of type 1 diabetes are recognized as occurring in adults. And
Mm.
autoimmune type 1 diabetes in Ramadan, approximately 1.9 billion Muslims celebrate ninth month of the lunar calendar or the Hijri month as Ramadan and observe fasting across the world. Islam has allowed many exemptions from fasting. They are like menstruating women, pregnant and breastfeeding women, prepubertal children, then individuals with acute and chronic illnesses, and individuals with intellectual disability, and individuals who are traveling. So, uh, in fourth exemption, where individuals of acute and chronic illnesses are exempted from this fasting, so we can take advantage of that. But many of the patients, they themselves voluntarily say that I have to fast, and for this spiritual well-being of their health, we have to go with the patients. And uh, this EPIDAR study conducted across 13 countries on almost 13,000 adult patients showed that 78.7% of individuals with type 2 diabetes and 42.8% of with type 1 diabetes fasted for at least 15 days during Ramadan. Means approximately half of the type 1 diabetics in their study fasted for at least 15 days. Then Saudi Arabia has maximum number of individuals with type 1 diabetic who chose to fast during this study. Then fasting, the potential complications and safety, we should discuss what is the newer thing. The hypoglycemia, first of all, the most dreaded complication in uh, type 1 diabetes is hypoglycemia or diabetic ketoacidosis along with dehydration. So, hypoglycemia in EPIDAR study of 1070 adult individuals with type 1 diabetes reported that fasting during Ramadan increased the risk of severe hypoglycemia to 7.5 folds, mean 750%, means a very huge increase of hypoglycemia is there. During Ramadan, approximately 2% people with diabetes experience at least one episode of severe hypoglycemia requiring hospitalization, and hypoglycemia has been typically encountered during the hours of preceding iftar. And this is, I must tell you, a very interesting habit of a fasting person, that as they close to the iftar, they refrain from uh, breaking fast, and they say, okay, there are few hours left or half an hour left, I will bear upon. And that is the time when the hypoglycemia get worse and it turns to severe hypoglycemia, even hospitalization occur. So if the level of blood glucose below 70, as per the Sharia guidelines, as per the medical guidelines, they have to break the fast immediately without delaying it further. So again, the next dreaded complication is diabetic ketoacidosis. Fasting increases the level of glucagon, accelerates lipolysis and ketosis. And episodes of diabetic ketoacidosis has been reported during Ramadan fasting, and detection of euglycemic ketosis during fasting requires the evaluation of acid base state, then blood glucose and ketone values to differentiate between decay from ketosis due to prolonged fasting. This is one of the interesting things, that during fasting, without decay, ketosis can occur. And sometimes once we see ketonuria of a minor grade, say +1 ketone or +2 ketones, and we say that decay has already been there, we should have acidosis in blood pH, we should have decreased BICA, decreased pH, then ketones, and along with increase in blood glucose level. But because of fasting, there can be a euglycemic state. So, hyperglycemia should not be considered a very significant sign during fasting. We should rely upon the acidic milieu along with ketosis. Then old school recommendation for 2017, and even in IDF guidelines of 2017, they suggested that even well-controlled type 1 diabetics are at high risk of acute complications and should not fast. They have used the word should not fast. Then ADA working group have repeatedly supported the classification of type 1 diabetic patient as very high risk groups, and also recommended not to fast. So these are the old school recommendations that has been changed now, and new school recommendations and newer recommendations by IDF DAR classification 2021 guidelines. They say that type 1 diabetics who wish to fast during the month of Ramadan can be allowed to do so after a proper risk scoring. A pre-Ramadan assessment and individualization of the risk score should be there. It is not a red flag sign that when the patient is type 1, they should not fast. There are certain criteria based upon the A1C, based upon the DKA episode in the previous history, based upon the hypoglycemia, and based upon the comorbidities. According to that, they should choose fasting medically or not to fast. Then IDF DAR guidelines suggested that allowance fast cannot be generalized across to all individuals with type 1 diabetes, especially that are considered as high risk groups. What are high risk groups? A1C of more than 8%, recent history of decay in previous 3 months, recent history of hypoglycemic unawareness, then CAD, chronic kidney disease, if and severe retinopathy, proliferative diabetic retinopathy. These are certain things that are exemptions in medical recommendation that patient should not fast. Otherwise, the patient can fast provided they have a stronger support system, CMBG facilities, and preferably CGMS facilities, and they are on the basal bolus regimens. So, pre-Ramadan fasting diabetic education, this is very important subject, that once the crescent appears for Ramadan and the type 1 diabetic start fasting, it should not be there. And if they wish to fast, we have to ask the patient priorly that before a month before Ramadan, you should come to us, and then we have a whole body checkup, and then we will tell you what to do and what not to, what are the do's and don'ts, and either you are able to fast or not. So this is the pre-Ramadan fasting. Pre-Ramadan assessment and education are vital to ensure the suitability and safety of fasting in young people with diabetes. Pre-Ramadan fasting education include then fasting focused education, medical assessment including the evaluation of hypoglycemic awareness, optimization of glycemia before fasting, frequent SMBG, the use of real-time CGMS or intermittent scanning CGMS, then immediate breaking of the fast to treat hypoglycemia. The patient should be agreed upon this. Then structured education has been associated with the reduction of risk of hypoglycemia and A1C improvement, and at least 61% decreased in diabetic acidosis in adults is in type 1 diabetics is found in structured education. If we give structured education, we can reduce decay risk to more than half. Then individuals with type 1 diabetes who received Ramadan focused education showed more willingness to fast. Then DAR practical guidelines in 2021 suggested that individuals with diabetes wishing to fast and receiving pre-Ramadan education and assessment should fast for few days during the 2 months preceding Ramadan. Means they should take as fast or chance of fasting during this Shabirat and Rajab period, whether they are able to cope up with fasting requirements and they are able to cope up their natural lifestyle. So, telemedicine has played a very important and crucial role since the COVID pandemic, and telemonitoring of glucose levels and insulin levels has an aspirational goal to a de facto standard of care for type 1 diabetes management. And DAR global survey on 1483 Muslim participants with type 1 diabetes has shown that 26.8% of those aged less than 18 and 73.2% aged more than 18 fasted during Ramadan of 2020 amid the COVID pandemic with the help of telemedicine. So, telemedicine can be an important tool for fasting in type 1 diabetes during Ramadan. Blood glucose monitoring during fasting. Frequent blood glucose level measurements are needed for safe fasting, and this should not violate the observance of Ramadan. SMBG remains the most widely used method for monitoring, but use of continuous glucose monitoring system can greatly facilitate insulin adjustment. Studies suggest that adolescents with type 1 diabetes could use CGM to fast without any hypoglycemia or DKA. Then insulin regimens during fasting, multiple daily insulin injections or continuous insulin infusion techniques are preferred regimens in type 1 diabetics during Ramadan. Use of pre-mixed insulins require fixed intake of carbohydrates at the set times, and it should be avoided as far as possible. Then insulin pump therapy, where circumstances provide continuous insulin infusion or pump therapies, should be used with adolescent in type 1 diabetics. Then there are certain systems that in pumps that low glucose suspend system feature of continuous subcutaneous insulin infusion has been shown to be beneficial in type 1 diabetes during fasting. And one more technical advancement, that is predictive low glucose suspend, that is coming in recent CGMS devices, has been shown to be beneficial in type 1 diabetic during fasting. Then insulin management during fasting, what the physician should recommend to the patient during fast. Current recommendation for type 1 diabetics on multiple daily insulin injections is including a reduction of total dose of insulin by 70 to 85% of pre-fasting total daily dose, or 60 to 70% of the pre-fasting dose of basal insulin. Then for the patient on continuous insulin infusion, a reduction of basal insulin rate infusion by 20 to 40% in fasting 3 to 4 hours is recommended. Then newer insulin, a word about them. There are some data in adults, but more studies are needed in the pediatric and adolescent age group. Insulin glargine U300 that is available in our country and degludec insulin have better pharmacokinetics and more flexibility and better quality of life as compared to other basal insulin. And the patient, if they have brittle diabetes or sudden hypos and hypers, they can be shifted to these insulin during Ramadan. An Orion study with type 2 diabetics with insulin glargine U300 found lower risk of hypoglycemia and improved glycemic control during Ramadan. And Hassan et al. Shown that in type 2 diabetic adults during fasting, insulin degludec along with aspart that is available in our country is effective, safe, and well tolerated. Thank you for the patient listening. That was all from my side. Thank you.
Thank you so much. That was an excellent presentation with and you alluded to the most important points. We see that children, I mean, they are very enthusiastic about fasting because it's a question of their self-esteem and feeling good. So they are rather willing to fast. And the two important things you highlighted, the risk of severe hypoglycemia goes up a lot. And of course, we need to differentiate fasting ketosis from decay. Those are very important points. And so the general message is that now there's no such blanket statement that the child can fast or cannot fast. You have to assess. You have to assess what is the level of control, how much they are conversed, regarding hypoglycemia symptoms, and whether they can adjust accordingly, whether they can monitor properly. So all these things taken together, we can advise our patients accordingly, whether they can fast or they cannot. Okay, so I think with that, we can go for questions. Dr. Nilavani?
I think questions only Shehla.
Ma'am, I no, this is a question I received from Dr. Rao, ma'am, and he wants to know, Dr. Syed, that is it right to allow type 1 diabetic patients to fast? I mean, this is received with the back end, and he wants to know is yes, we are saying that I mean the Islam specifically says that in high risk patients who are ill, you are not supposed to fast. So when we are, I mean, when we are sort of presenting data which shows that patients can fast, I mean, I mean, if you could just, maybe just summarize 3 or 4 key points where, okay, this patient maybe with proper monitoring, I mean, I will reframe part of what he said, maybe with proper monitoring, as Madam said, with absolute, a very, very well-informed patient along with a very well-informed family. Because in a young patient, I think it's very important that a family is equally educated when we are, looking after children who are going to fast. So, Doctor said, if you could tell me 1, 2, 3, okay, these
Yes,
people, maybe you can think about it. Would insulin, and the second question, which is from me actually now, the second question is from me. What about patients on the insulin pump? I mean, we have an increasing number of patients on the pump. What would the data say?
Yes, sir. Ma'am, firstly, I would like to draw your attention that as per the WHO definition of health, spiritual health is also taken into account. And if the patient is not fasting, there is a detriment to the spiritual health of the patient. So if there are aspirated and they have a zeal to fast, they should be allowed, and with certain exemptions, like patient with poor glycemic control at the baseline. The patient coming after, say, 15 days prior to Ramzan with the A1C of more than 8, they should not be allowed to fast. Patient having hypoglycemic unawareness previously, patients who are being hospitalized to severe hypoglycemia in previous 3 months, patient with a history of diabetic ketoacidosis in previous 3 months, patient who are already having severe grade retinopathy, proliferative retinopathy, patient who are having CKD, CLD, CAD, patients who are pregnant, they should not be allowed to fast medically. And if they are minors, say 10 years, 12 years, they should be adults, at least 18 years, with a A1C of, say, between 6.5 to 7.5 or so. No history of previous severe hypoglycemia previous 3 months, no history of hypoglycemic unawareness, and no history of diabetic ketoacidosis, along with strong family and medical support. They should be having medical services at their disposal, like telemedicine. They can communicate to the doctor. If they are busy in waiting queue for a busy OPD in a hypoglycemia, that is very much risky for their health. So this is my take on this. Then you have asked a very good question about rule of use of CGMS and insulin delivery systems. So smart devices like Dexcom we have, and recently introduced, and this Abbott people coming with a new device, that is a smart device where sensors and pump, they form a closed loop. So patient has to train that loop, that's it, according to their daily activities, nothing big. But if they are using the previous devices where they are having an open system, it's not a closed loop. So they have to feed the device with SMBG data, then they have to reduce the basal insulin dose by at least 30 to 40% in last 3 to 4 hours before iftar, as the natural things occur. And they have to increase the bolus during iftar, and the suhoor bolus should be at least say 40 to 50% of the previous breakfast bolus.
Thanks for that. Thanks, Dr. Sayed. Ma'am, any other questions?
I have a small doubt. This is kind of concern. So, very nice presentation, Dr. Syed. And I think regarding the hypoglycemia or hyperglycemic emergency like diabetic ketoacidosis and all can be managed with the changes in the with the newer devices, insulin pumps, with the changes in the dosages, and with the newer technologies like so low sustained glucose and all, we can identify very early so that we can abort all those episodes and all. But one more concern concern is because almost 12 or 14 hours they will not take anything, even water also. So I think how to maintain, especially now it is coming in the month of March or April, like especially in the summer months, how to maintain the hydration, because I think that's one more concern for the type 1 diabetes, because it's very important to maintain the hydration. Any tips or any something like
Yeah.
that, because I think I know, as far as my knowledge is, they will not take even water also.
Yeah, you have asked a very pointed a very good question, that what about hydration part? So there is a freedom in Islam that you can count upon 30 fast. If you are extremely ill and the weather is not allowing your health, in the weather where it's easy to fast, like type 1 diabetics, they can fast from 25th of December to 25th of January, where the water requirement is very less, days are very small, and then they can observe fast. I usually ask my patient that suppose you are having water and you have issues regarding thirst and hydration, you can fast on those days. And it has been said that even in pregnant women, if they are pregnant, they can observe those remaining fast in the days where they are non-pregnant. Similar with the menstruation, and similar can be the illness.
And we will not allow them to walk in the sun or something like that,
Exactly.
again, just to conserve the water, whatever they have taken in the morning. So thank you very much. I think
And I had
yeah.
just another small
Yeah.
query.
Yeah.
What about exercise? Children, they will be going out and playing in the daytime. So what should be the advice in that regard?
So,
I mean, they
ma'am,
may be having,
yeah.
yeah,
So,
please go ahead.
type 1 diabetics usually should fast when they are adults, matlab above 18 years. So they take care of the things. And even in Islam, the fasting is mandatory after 15 years or so, once the puberty is attained. So it's not for young kids. And even if in adults they want to have an active lifestyle, they should exercise in Taraweeh hours, like once they are fed. They should not put their extremes of exercise before aftar, after say 3 or 4 p.m. It's very difficult to even
Yeah.
exercise, or they have to exercise just after suhoor, once they have the meal.
Thank you. So I think great going. So we'll move on to the next session. So that is technology and fasting by Dr. Shaktivel. So over to you, Dr. Shaktivel. So I think he is going to highlight on how to use the technology to safeguard our patients, to whoever are wishing to go for a fasting. So how best we can reach the targets, avoiding the hypoglycemia or hyperglycemic emergencies. Over to you.
Thank you, ma'am. Amal, can you please introduce Dr. Shaktivel?
Yes, ma'am. I would like to now introduce Dr. Shaktivel Siva Subramaniam sir. Sir is a consultant endocrinologist in the Hormone Clinic in Trichy, Tamil Nadu, and sir is contributor towards various journals and authored many chapters in various books. Sir is fellowship. Sir has fellowship of International Short Course in Tropical Medicine from CMC Vellore, fellowship in diabetes and endocrinology from Manipal Institute of Health, Bangalore, fellowship in European Committee of Sexual Medicine, Amsterdam, and MRCP specialty certificate examination in diabetes and endocrinology. So I would like to call upon Shaktivel sir for the presentation.
Good evening, everyone, and thanks for this opportunity. Are you able to hear me? Yes?
Yes, we can hear you, sir.
So firstly, I would like to thank the ESA for having given me this opportunity. And I think most of the topics, questions which are put forth to Dr. Syed would be addressed by what I'm going to present now. I will first start with sharing my slides. Are you able to see my screen? Is my screen?
Yes, Shaktivel, we can see. Just give it a presentation mode.
Yeah. Thank you so much. So the topic given to me was on fasting and technology. So I was in two minds as to should I be talking about fasting and technology only related to Ramadan, or should it be on general? So what I've done is I've tried to add both here. And so it will be first on fasting and diabetes as such, what we want to monitor during fasting in the general way, and not only towards Ramadan, and then how we monitor using sensors. Because this is about technology, we will then take it one step further into the future, which is the Internet of Things. Now, having said that, everyone knows that the numbers are going to go up by each year, and therefore India is the diabetic capital, and we know that diabetes is quite prevalent and rampant in India. The question here is about fasting, and that too in a diabetic. We all know that we as human beings, we follow the circadian rhythm, and therefore there is going to be a cycle where we are going to have food for 12 hours, and we usually have a natural fast for the next 12 hours. And the advantages of that have already been projected by so many other studies. The topic here is about what are the, and we all know about the advantages of fasting, how fasting helps in various mechanisms, right from the mitochondrial to stress, chromatin modification, inflammation, protein synthesis, and so on. And also about the normal circadian pattern by which the hormones are also regulated. Now, the problem here was to identify the problem, which is basically the fasting person. As ma'am had already asked Dr. Syed as to type 1 diabetes, how are we going to look into kids when they're going to have dehydration or they want to play and so on? I think we'll try to address that here as well. So we are talking about fasting in a diabetic, and therefore the problem here is the person. We all know that conventionally they are going to be, we're going to segregate them based on the type, either type 1, gestational, type 2. And we have tests to know whether they have diabetes, and we have the regular conventional management. But what happens when you're trying for a fast, and that too during Ramadan? And Ramadan is a global phenomenon. And the fasting pattern is quite well known throughout the world. So there is this going to be a significant change in their lifestyle when they're going to fast during Ramadan, and there are going to be advantages and disadvantages as highlighted here. The sleep schedules are going to change, the meal plans and diets are going to change, physical activity patterns will change, and also medication adjustments and also reduction of other vices are going to change. There are going to be advantages. There are also going to be some disadvantages because of this. And we know that here we are going to talk about the different, the type of fasting here is going to be different. So it is going to be from dawn till sunset. And therefore, usually the monitoring has to be stringent so that we are able to make sure that the sugars are neither going up nor going down. So the answer to this is first to calculate the risk, which means there is already a risk calculation questionnaire already available where they're looking into 16 parameters, and of the 14 parameters, sorry. And of the 14 parameters, it includes the type of diabetes, duration of diabetes, presence of hypoglycemia, level of glycemic control, whether it's less than 7.5 or 7.5 to 9 or more than 9, the type of treatment they are on, any self-monitoring, any acute complications, comorbidities, renal complications, pregnancy, frailty and cognitive function, physical labor, previous Ramadan experience, and also the hours of fasting, whether it's going to be less than 16 or more than 16. So based on this, they are able to score the person first. And once the person is scored, we will know whether the score is between 0 to 3, 3 to 6, or more than 6. And therefore, they will fall into low risk, moderate risk, or high risk. So we are first going to classify the person based on his or her history into any of these risk scores, and only then plan whether they're going to fast or whether they're going to fast with supervision or whether they're not going to fast. So if it's going to be low risk between 0 to 3 points, yes, fasting is probably safe. And moderate risk, fasting safety is uncertain. Whether when the risk is going to be more than 6 points, it is usually unsafe. Now, having done the classification, the next thing we usually do is still educate the person as a Ramadan-focused educational program, where we look into, again, about once the risk is quantified, about blood glucose monitoring, fluids, about physical activity, medication, when to break the fast, and recognition of symptoms. But after educating comes the change in pills, which we are obviously going to follow. And then we plan for the risk stratification pre-Ramadan itself as to whether which risk category do they come into, what is their score, and what would be our plan of action once the Ramadan sets in. How are we going to monitor them? Are we going to use a 7-point profile and so on? Now, if you're going into fasting and technology, that's what when we were discussing about two aspects. One was about the family support and second was about the doctor support. There's a third aspect, and that is the technical support or the technology support. Because here we need monitoring, and the monitoring has to be intense. Again, it depends upon the type of diabetes they have, but the monitoring has to be intense. So mostly it's a 7-point monitoring system that we use. Now, how do you design a point of care device to monitor? As per the WHO, there is an acronym called REASSURE, and the criteria is that it should be based on REASSURE, which means the testing or the point of care testing should be rapid and robust. It should be equipment free. It should be deliverable, affordable, sensitive, specific, user friendly. It should have real-time connectivity and the ease of specimen collection. Only if a point of care device has these properties, only then it is an ideal point of care device as per the WHO. Now, having said that, if you're going to monitor a person for diabetes, previously we used to check sugars, venous blood, which is a bygone era. Currently, we do blood glucose monitoring, self-monitoring of blood glucose, which again is now slowly phasing out. What we are now trying to do is embrace the new era, where we have come a long way in terms of how are we going to monitor sugars, whether it's going to be invasive, it's going to be minimally invasive, or it's going to be non-invasive. So ideally, technology-wise, what we use right now are mostly minimally invasive and non-invasive. And there are different modalities by which these minimally invasive and non-invasive act. But whatever the method it is, a glucose sensor has to pass through two phases. The first phase is the ideation and identification of the technique, the prototype design, testing, and the second phase would be the clinical trial, the accuracy of assessment, and then the launch into the market and the post-market surveillance. That's how the glucose sensing happens. What we usually use is our glucometer, and now we also use the CGM, the continuous glucose monitoring system. By using the CGM, we are able to see whether the sugars, the pattern of the sugar, it's more like a movie rather than one snapshot. And then we are able to see the entire, the ebbs and flows of the sugars. And therefore, we are able to see whether it's within the time and range is good or not. Now, having said that, there are 6 types of continuous glucose monitoring. The one which we use is the CGM system is located near the critical cardiac patients in the intensive care unit. The other is a Bluetooth energy implantable glucose monitoring system. The third is a long-term implanted sensor system. And fourth is a NIR, which is a non-invasive, which uses infrared. The fifth is a blood glucose monitoring system based on wireless body area networks. And the sixth is a monitoring system for type 2 diabetes, which can make decisions on the diabetes control and predict the future glucose levels as well. So these are the 6 types of glucose monitoring systems available right now. But again, it depends when you are trying to take or choose one type of a glucose sensor, there are certain things which we need to consider, right from the economics to the sensor size, the life of the sensor, the number of times you have to calibrate it, or whether calibration is required at all. For example, in the flash glucometer, we are not going to use calibrations. And then we're able to share the data or not. So when you're looking into the recent glucose detection technologies, we are both for invasive and minimally invasive. We are looking at modality of things, not only into blood, we are also looking into saliva, tears, and so on. And also the way that we are monitoring is not only about optical or nanotechnology, but also electric methods, thermal, and so on. I just wanted to touch base with some of the newer technologies which they use, which one is the thermal sensor, which uses this phenomenon of thermal emission spectroscopy, by which they're able to, the principle here is that the glucose levels affect the body's heat distribution, which in turn affects the emitted thermal radiation. Therefore, no penetration of light or wavelength is needed for this measurement technique, and it does not require calibration. And the glucose molecules have specific absorption characteristics in the infrared region. Therefore, by detecting and analyzing this emitted thermal radiation, it is possible to indirectly estimate the glucose concentration. So this is one type of a sensor which is now being used, which is a thermal sensor. The other sensor which is now being used is called the diffuse reflectance spectroscopy technique by an intermittent finger sensor. And this is a promising technique which is currently being tested for wristwatch devices as well, like this type of a device, where they're using this technology to again look into the blood glucose levels. But again, as I said, when we are looking at a fasting person, we are looking at once we have risk stratified them, we are looking at self-testing by monitoring them. And then the next one is about continuous monitoring if possible, rather than just self-testing, because that's only a snapshot and this is more of a movie pattern. And then comes the wearable devices where the emerging technologies are now coming into play, which are more non-invasive. Ideally, a glucose monitoring system should have, we look into the diet planning, then we look into a method by which we are able to monitor them, either invasive or minimally invasive. Then we should have a predictive analytics so that we are able to give solutions to time-dependent problems, and preferably if they're going to be wearable devices. And it should also allow the person to move about. So the person should be able to do his regular daily activities as well. We also now are also looking into sensors and devices which are now connecting to apps, and therefore we are able to share the data with other people, including the health personnel, and therefore we are able to get advices real time. But what about going beyond sensors? What is the next thing about beyond sensors? That is called the Internet of Things. So this is about the evolution of the Internet of Things, called the IoT. Like previously, we used to have a human-to-human pre-internet era. And then we had the WWW, which is the Internet of Content, followed by the Internet of Services, which is e-commerce and e-productivity. Now we have social media, which is the Internet of People. And slowly we are moving into a machine-to-machine, which is called the Internet of Things, which means the machine itself will be able to identify, it will track, monitor, and it will also be able to decide and give a response to whatever has been monitored. That's called the Internet of Things. Now, there's always a 4-step process for the IoT-based healthcare system. The first consists of deployment of devices, which is basically the sensors, the monitors, and so on. The second is the data which is received from the sensors are in an analog form, and then they are digitized. The third is the digitized one is aggregated, pre-processed, standardized, and then moved into the cloud. And the final stage is analysis of this data, and this helps in decision making. So this brings us, the IoT or the Internet of Things brings us to the new era of artificial intelligence. Now, artificial intelligence basically is of two types. One is based on the level of intelligence, and the second is based on the behavior and capacity like the human brain. One is based on behavior and another is based on intelligence. The other way to look at it is whether it's based on the capability or the functionality. So when you're looking at artificial intelligence, now artificial intelligence itself is an umbrella term where you have something called machine learning and then you have something called deep learning. So any technique that enables a computer to mimic a human intelligence using logic and decision trees is called artificial intelligence. A subset of artificial intelligence that includes statistical techniques that will enable the machine to improve a task with experience is called machine learning. And deep learning is that subset of machine learning which is composed of algorithms that permits a software to train itself to perform tasks like speech and image recognition by exposing multi-layered neural networks to vast amount of data. So that's called deep learning. So now what we are trying to do is there are different types of machine learning: supervised, unsupervised, semi-supervised, and reinforcement learning. Now, when you're going to give data to a machine learning, it will make it into an algorithm and then it makes a model out of it. And so that when the new input comes in, it will try to apply it to this algorithm and then predict it. So that's how machine learning happens. And then the recent trends are about blockchain meeting machine learning, AI-based self-service tools, enhanced augmented reality, full-stack deep learning, and generational adversarial networks, GAN. Now, why are we trying about all those things in technology and fasting and diabetes? Is because when there is a person with diabetes and we are using sensors to monitor them, we are then slowly trying to take that data, record them and transform them into an app so that it goes to the healthcare provider. From the app, it goes to the database, and from the database, after analysis and processing, it reaches the healthcare provider. The healthcare provider is then able to make a decision, and the decision is then sent real time towards the person. So data collection followed by, as I said, Internet of Things, which is AI data processing, which helps in the decision support system real time. This is again the same thing. So what happens here is, one is you have the baseline measurements which are done by CGM, and then after the CGM time is over, you use the post-CGM method to look into data and then look into what are the recommendations or predictions which can be done from there. This can also be applied for inpatient monitoring. Like a problem is selected, the data is collected, the machine learning happens, validation happens, the assessment of the impact is done, and then it is deployed and monitored. So the idea is basically to sense the fluctuations in sugars. And as someone was asking about type 1 diabetes, we are also looking at the insulin loop. Here it is about the entire loop, which is basically from the sensing till giving the insulin dose. Everything can be done by machine learning, which is called the IoT, the Internet of Things. So basically, we are trying to close the loop as far as diabetes management is concerned by doing a continuous glucose monitoring, then using insulin delivery devices, and therefore a closed loop system. So thank you so much for this opportunity, and I hope this talk on fasting and technology throws some light on the new things which have arrived into diabetes management. Thank you.
Thank you, Dr. Shaktivel. Such a nice presentation. I think very advanced. Hello? Hello, any questions? I'm just trying to see in the chat box.
One question of Shakti, how do you manage to make such nice slides?
I had to read a lot.
Sorry?
I had to read a lot.
Yeah, I was just wondering. I was overwhelmed by the slides only. I was just trying to
I know.
see for this. Shakti, I just wanted to ask a simple question: is that what would be the, when we are talking about hypoglycemia, like when we talk about the CGMS, we talk in terms of trends. When we are looking at our patients in Ramadan, where there's a risk of hypoglycemia, would you use some kind of different, when you see a downward trend only, you would tell them to break the fast, or you would tell them that no, you need to see that you actually go into hypoglycemia and break the fast? On CGMS, would you give any kind of different advice, or would the advice stay the same in a patient who's fasting?
Ma'am,
in the hypoglycemia range.
I think whenever a person has an hypoglycemia, then we need to break the fast because it's a medical emergency. So there are no, the thing is, how are we going to use this data so that in the future we can predict a hypoglycemia? So the idea was not only monitoring right now, real time, how can we predict in the future, and therefore we prevent hypoglycemia. That is how these technologies help us so that the person does not fall into. So even before the fall, or when there is going to be a rapid change in the blood glucose, it will give triggers, and therefore this trigger will go to the doctor, and doctor will be able to then monitor the patient. So okay, that is how technology will be helping.
So it would also help us change therapy subsequently for your patient and readjust subsequently.
It can predict the pattern, and therefore we can give us an alarm even before it happens.
So basically, it would help both in preventing hypoglycemia also to a significant extent. Once you see the downward trend, maybe the patient a little more aware that, okay, I need to be a little more careful. I'm potentially going to go into hypoglycemia.
Yes,
so it would help you prognosticate that also.
Correct.
And if there is limited resources, like would you tell the patient to, for example, apply the CGMS maybe in the first 15 days of Ramadan, or just because I always feel that the maximum adjustment which needs to be done is in the beginning of Ramadan. So would you, we have very, very restricted resources. Our patients pay from their pocket. So would that be easy, or would there be certain specific criteria? For example, if the patient has hypoglycemia, use it as a criteria to maybe definitely apply a CGM? Would you use age as a criteria, or would you show the risk stratification score? I mean, would that risk stratification score decide which patient needs to go on more intense monitoring? If in
Exactly.
2 or 3 scenarios where you could say, okay, this is the audience needs to know. If this is there, please think in terms of CGM.
So this is an exacting game. I was trying to gamify this. Basically, you have this course. So you talk to people who are planning for Ramzan. Okay, you take this game. There are 16 questions answered. Answer these questions. Let us know your score. Once we know the score, then we can put them into high risk, medium risk, or low risk. And once you know whether they're medium risk or low risk, and therefore the advice to them changes. The question was I didn't get the question, ma'am. What? Your question was?
I'm asking which patients you would say absolutely you need to do a CGM. I mean, you need to, if you're fasting,
I think
do a CGM.
I still CGM, as you said, is we have some financial constraints as well. So we still go with finger stick most of the times for people who cannot do a CGM. But if you think it's going to be very volatile, we're going to have hypos and hypers, then we are, as you said, for the first initial part of the fasting, a CGM would be very useful. But if it is not possible, then we still go for a finger stick method.
Thanks.
Just had one question. That is, I mean, what data do we have to support that, okay, this intense monitoring would help us to avoid hypos, decay? I mean, we are assuming that it will avoid, but do we have any definite data in this regard? That application of technology during Ramadan fasting has actually improved the picture?
I don't think so, man. I have not come across data during Ramadan. Maybe I think these technologies have been developed only over the last few years. I think we'll be getting data soon. Maybe this Ramadan fast itself, we would get some data as well.
Yeah, so Shaila, keep that in mind. We need data. Okay, are we really improving? Yes. Okay. Good. Thank you.
Thank you.
So it was a very high tech. It was a very high tech.
Very, yeah. Right.
Excellent. Excellent.
Right.
Thank you.
Right.
Thanks for that, Shakti. Amar, can we go to our next speaker, Raja, please?
Yes, ma'am. Thank you so much, Sakti sir. And now I'd like to call upon Dr. Suziani Binte Zainuddin, ma'am. Ma'am is Senior Consultant, Department of Endocrinology, Sengkang General Hospital. And she's a Clinical Assistant Professor in Duke Graduate Medical School, Clinical Senior Lecturer in Yonglu Lin School of Medicine, National University of Singapore, and Adjunct Senior Lecturer in Lee Kong Chian School of Medicine, Nanyang Technology University. Sorry if I have mispronounced any of the names, ma'am. And ma'am has avid interest in community programs, population health, and diabetes care. And ma'am has received National University of Singapore School of Medicine Award for her teaching excellence. Apart from that, ma'am has led multidisciplinary team in integrated diabetes care in UK, King's College Hospital, London. And ma'am has pioneered various integrated care programs in diabetes. Ma'am will be talking on diabetes and CKD. Is it safe to fast? Over to you, ma'am.
Ma'am, Dr. Suziani, before you start, I really want to personally say big thank you. And the reason I interrupted was because Dr. Suziani has done phenomenal work in the Ramadan field. I mean, she's one of the, really names we go to for any kind of, query, any kind of conversation regarding Ramadan, this side of the globe. So thanks for agreeing to be a part of our meeting.
Thank you. Thanks, Sheila, and thanks to all the organizers for the invitation. I just want to check that you can hear my voice.
Yes, we can.
Yeah.
Thank you.
All right. Okay. So quite happy to be here. I see such a good program indeed, and it was quite amazing listening to the earlier speakers as well. So I'm going to proceed with the talk that Sheila have asked me to give. Diabetes and chronic kidney disease, is it safe to fast? So let me just proceed to the next slide. Yeah. So my disclosure is that I don't have any conflict of interest pertaining to this talk. So I'm just going to cover on several things. So what do and what don't we actually know with regards to diabetes in CKD and fasting? We do know that there's actually quite a couple of fasting studies in CKD, but we also know that there has not been many studies with regards to CKD in diabetes, especially for fasting. So I'm just going to go through the fasting studies that we already know, the DAS risk calculation, which is based on these studies which were done earlier, slightly more recent evidence, and whether finally at the end of it, can we come up with a conclusion and a statement as to, is it really safe to fast? So the categories of renal patients we know and the studies that's available are divided into three categories. First of which is our chronic kidney disease, stages 1 to 5, the end-stage renal disease on dialysis, whether it's peritoneal dialysis or hemodialysis, and then our renal transplant patients. So what do actually we know? Well, many studies in CKD have already been published, meta-analysis. There are at least a few, even the most recent one in about 2022. But these studies are mostly without pre-existing diabetes, which means that the diabetes actually exists before the renal condition comes up, before they are actually having developed other issues, right? So the consensus based on this is that those with stable renal function could actually safely fast with transient changes occurring, which are not long-lasting. But are these actually applicable to patients who have CKD because of diabetes, as in what we are discussing today? So let's look at a couple of studies which are also highlighted in the guidelines, which we know do mention that they have a proportion of patients with diabetes and CKD. Of note, the studies which do mention about the proportion of diabetes patients actually range just from about 8% to about 30+%, which means that it's actually not very large proportion of the whole study population. So I could mention a few studies here, one of which is Al-Wakil, the topmost in this table on the right, that was done in 2007, which actually showed in a comparative prospective study where all the CKD patients were evaluated pre-Ramadan during Ramadan, and then a mean change of eGFR was measured and compared to healthy volunteers. Only 20% of these CKD patients actually were caused by diabetes. So in this study, it was shown that there's increased level of urinary NAG when compared to healthy individuals that fasted during Ramadan. And what does this urinary NAG really mean? Well, increase in urinary NAG is actually associated with blood glucose levels. So this actually tells us that it is important to ensure that glycemic control is actually a good control among those with diabetes. How about the other study by Mbaki, some years down the road as well? It actually showed that for individuals in CKD, where all the participants were diagnosed with CKD, but only a small portion, just about 8%, had insulin-requiring diabetes. And the whole study group were actually separated into 3 groups based on their renal function and evaluated before, during, and after Ramadan. So in this particular group, it is shown that the patients with CKD could experience deterioration in the renal function, especially those with CKD 3B and above, those with eGFR less than 60. And out of these patients, it is shown that 11.7% that fasted during Ramadan actually experienced acute renal failure. Well, the main risk for deterioration is, like I mentioned, and we do really remember that out of this group, only about 8% actually have insulin-requiring diabetes. So how applicable is it for this group that we are referring to today? So how about the third study, which is Bakit, which showed that there is a higher stage of CKD, the worse the renal outcomes. Well, in his study, all the participants had CKD stage 3 or higher, and 38% has diabetes, so a bit more than the other studies mentioned earlier. The clinical and biochemical measurements were taken before, during, and after Ramadan. And around a third of patients had experienced deterioration, and the effect was increased in the later stage of the CKD. So increases in the creatinine level were sustained after Ramadan. So will this mean that do we have to be a bit more concerned for patients of higher stage of CKDs, which means that 5 compared to 3 will be of actually higher risk to eat during fasting in Ramadan? And will that be something that will be a longer term effect, even though fasting is just about 4 weeks? So are there any other effects that we know that is concerning when it comes to fasting for our CKD patients? Well, the other study that's also indicated here did show that, well, in participants who are patients presenting to clinic with CKD, these participants were split into 2 groups: fasting, about half to half, fasting, about 52, and non-fasting, about 54. Well, eGFR and biochemical measurements were taken before, during, and after Ramadan, and the mean difference was actually calculated. Well, it did show that there was worsening of kidney function during Ramadan, and that it could potentially progress with worsening outcomes after Ramadan, as the creatinine level rose by about 60%, and remains so in about a third of these patients. Well, the issue was that it also noted that there's an increase in the risk of cardiovascular disease amongst the patients who actually fasted during Ramadan period. Of course, as is expected, so there are some patients who continue to fast despite the worsening outcomes. So I guess we do need to actually educate our patients appropriately, but we do know that no matter what we are going to tell them, we do need to still teach them what are the safe practices, because they will still continue to fast if you don't do the teaching as to what needs to be done if they decide to fast. So is it all doom and gloom for CKD patients? Well, there are some studies that show otherwise. Well, in the 4 studies that's shown here, well, it does look like there are potentially positive outcomes during fasting, due to fasting in Ramadan for CKD patients. So in the study here, done by Bennett et al. In 2010, that shows that there's improved eGFR during and after Ramadan in the outpatients that was studied. In a study that had stage 1 to 5 CKD, 61% of the cohort, larger than the previous studies, had diabetes, and clinical and biochemical measurements were taken before, during, and after Ramadan. And it was shown that there's improvement in eGFR, and it was statistically significant difference. And it does show that there were no significant changes to biochemical measurements such as urinary electrolytes, protein, or osmolarity that would be a concern. How about a study that by Kara et al. About 7 years later, it shows similar outcomes. In this study, we have a slightly more patients with more advanced CKD of stages 3 to 5. These individuals, half of which fasted and half did not fast. So 45 fasted and 49 did not fast. 32% of them had diabetes, so about less than the previous study. Similarly, the measurements, clinical and biochemical, were taken before and after Ramadan. So it did show similar outcomes in the comparative study of patients who fasted and did not fast. How about we did show any highlights that are concerning? One of which is that they did show that elderly individuals were at potentially higher risk of deterioration in renal function, something that will also need to be taken into account during counseling for Ramadan fasting in CKD patients. So, also meta-analysis that showed that the difference in eGFR before and after Ramadan. It did show that there was no clear or meaningful difference that was found. It did here, the 95 confidence interval. So that's And conclude then that even though there are not many studies in CKD that directly fasting in Ramadan, however, some of these studies, as mentioned earlier, have some proportion of patients who do have diabetes in CKD. So these are some of the signals that we can look into, but of course, as usual, just on the diabetes group will be necessary. So how about end-stage renal disease in dialysis, both in PD, peritoneal dialysis, as well as hemodialysis? Well, there are many more studies when it comes to dialysis patients, but can summarize here that, well, studies on the left, well, most of the studies did not show anything of concern. So Al-Wakil, they show that in a study of 31 patients on peritoneal dialysis, there is no associated mortality or morbidity. In a study of hemodialysis, for about 40 participants who actually fasted on non-dialysis days, there was no effect on weight gain, BP, or electrolytes. Similarly, another study support such an outcome as well with no excess mortality. Another multi-center study in USA at Saudi Arabia with more than 100 patients with diabetes also showed this in pre- and post-dialysis BP, serum potassium, albumin, or cardiovascular events between those who fasted and those who did not fast. Nearer to home, there are studies that were conducted in Malaysia, which showed that approximately half of the patients had diabetes and found that the fasting during Ramadan was associated with a reduction in weight and improvement in serum albumin and phosphate level. Well, that is a positive signal, but is it something that can be translated in our patients with diabetes, not just end-stage renal disease, but also end-stage renal disease in diabetes patients? A more recent study in Malaysia also found that there was reduction in BMI, interdilated weight gain, and improvement in biochemical as well. With improved serum phosphate, urine creatinine levels, although serum albumin appears to have fallen in this group. It was concluded then that these participants actually only experienced transient changes during Ramadan, and the fasting could be conducted safely. How about the other study in Palestine? Also similarly, almost half of the patients do have diabetes. So it is shown, unfortunately, opposite effect where there is increased in interdialytic weight gain after adjusting for diabetes and other socio-demographic factors. However, even though diabetes group does have an associated some biochemical changes, however, these are deemed as clinically negligible in this particular study. So some plus-minus signal there, some red flags to just take note of, but also some suggestion that potentially in certain selected group, there may be some positive changes. So, well, whilst it is suggested by some of these studies that fasting can be safely conducted during Ramadan without added complications, but studies which directly focus on diabetes in end-stage renal disease will need to be conducted to take into account the effect just on diabetes alone. So how about our post-renal transplant patients? We do know that there is a lot more concern when it comes to these patients because the medications need to be given very timely and they need to be monitored very closely because once they go into rejection, then there is quite a lot of concern. Well, there are studies which show both ways. So in these studies here, these 3 studies that's shown, Ghalib et al. Actually had a prospective study in Kingdom of Saudi Arabia, where the participants were prospectively followed for 3 consecutive Ramadans. And they were split into the fasting and non-fasting group, which means that both of these groups did not fast for the fasting for the non-fasting group, and the fasting group actually fasted for 3 consecutive Ramadans, so 3 years. And out of this group, of the study population, only about 1/4, right, 28% actually have diabetes. eGFR and other clinical and biochemical measures were compared between the groups across all the time periods. And it was found that the eGFR did not change from the levels before Ramadan to after fasting, even when adjusted for diabetes and age. Similarly, they found no differences in biochemical measurements between the participants that fasted and did not fast. The study was similar to another study that was done, which was a retrospective study, which was also done in Saudi Arabia. In Iran, a prospective study done by Inolahi, where the participants also had undergone renal transplant and were split into the fasting and non-fasting group, 19 and 20 respectively, consecutively fasted for 3 years as well. Biochemical measurements were taken before, during, and after Ramadan. There were no significant changes in the serum creatinine across the time periods. And all the fasting patients had stable renal functions and safely fast during the Ramadan period. Whilst this study did not show any associations with acute rejections of transplants or other complications, but there are other studies which do have some worrying signal. So let's go on to the next group of studies that I'm going to talk about. So in these 3 studies, Qureshi et al. Is the first study, where it was also done in KSA, where all the participants had undergone renal transplant, half of which 43 fasted and 47 did not fast. eGFR and biochemical measures were calculated during, after Ramadan, 1 month right after Ramadan, and 6 months after, and compared between and within the groups. It is shown that fasting did not adversely affect the renal outcomes. It did not actually affect the eGFR between the groups, as the group was actually divided into eGFR categorized as low, moderate, and high. Serum creatinine was also similar when compared within the groups. But however, when they actually compared, they noticed that those who were fasting had transplant earlier than those who did not fast, right? So they have a longer post-transplant period. So whether that makes a difference, we really need to evaluate whether it's similar in our diabetes patients post-transplant. So Syed et al. Also showed in a prospective study that there were no associations between fasting during Ramadan and changes to serum creatinine level. However, in type 1 diabetes patient, there is a tendency for higher blood glucose levels during fasting. Importantly, in this study, it was also shown that there were 2 cases of acute rejection and 3 cases of chronic graft dysfunction. So something to actually take note of, and it may be a signal that we have to consider. So although the general consensus was that fasting can be conducted safely in these individuals, but these are studies in individuals who do not have diabetes, pre-existing diabetes. So more research is needed into people with diabetes who have kidney transplants so that we can make more specific recommendations just for our diabetes patients with CKD post-transplant who are planning to fast. So in summary, in patients with CKD of low moderate risk may be able to fast with safely guidance from health professionals. CKD which are higher stages may be a bit more concerning, whilst fasting and dialysis appear that it may be conducted safely without added complications, but we do need to take note that these are in patients without diabetes. In fasting in stable post-transplant patients can be safe, but more research are needed in those with diabetes as well. So let's see what Diabetes and Ramadan International Alliance actually recommend based on these studies, which are already mentioned earlier. So we know that we need to evaluate with the 14 elements as indicated in the table on the left. And we know that in the 6th element on chronic complications and comorbidities, there are various gradings based on the renal function of the patient. So in CKD stage 3, Then when it's stable, eGFR of 45 to 60, well, it is given scoring of 2, eGFR 30 to 45, 4, and eGFR less than 36, which immediately at eGFR less than 30 drops the patient into high-risk category. Hence, even without calculating any other risk elements, just by the fact that the patient already have eGFR less than 30, already puts patient in high risk, and we should advise patient about the fasting, about advising them not to fast, and what are the alternatives to fasting, including payment of fidya and doing compensatory, other compensatory measures, right? In the patients who regardless decide to fast, very, very important for us to proceed with the pre-Ramadan assessment as early as possible, doing the evaluations and doing the necessary adjustments, whichever medications they're on, diabetes medications, as well as the other related medications, doing a very close Ramadan monitoring with regards to glucose, as well as other relevant investigations such as renal function or any other electrolytes, which is concerning. And during the post-Ramadan review as well, to evaluate and see what actually, what the patient actually experienced, and to reassess, because some of these patients will go on to fast during the Shawwal period and beyond the non-voluntary fasting, during the voluntary fasting, right? So how about more recent evidence for fasting, and specifically in DM-CKD? So I think Dr. Sheila was part of this study as well. So we do know that DAR Global Survey Study was done in 2020 as well as 2022. And so this is the data from 2020. So subgroup from the global DAR Global Survey is assessed for this particular CKD group. So in the study population of about 707 patients, there were about patients, about 16% of these patients were type 1 diabetes patients, and 83% were type 2 diabetes patients. In this group, actually, 65% of the type 1 diabetes patients and 75% of the type 2 diabetes patients with CKD were fasting. So when it comes to the age group, you can see quite a bit of difference. The type 1 diabetes patients were younger, at about 32 years of mean age. Type 2 diabetes patients were older at about twice that age, 60 years. There was a proportion which is similar for gender, with about 40% of females and 50+% of males. HbA1c was also quite similar, with type 1 diabetes slightly higher at about 8.9%, and type 2 diabetes 8.6%, and duration of diabetes was similar as well, at about 16 years and 15 years respectively. So these patients, quite a lot of them, when it comes to a type 2 diabetes who are on insulin, almost 70% of them were on insulin. So what was the difference when it comes to type 1 and type 2 diabetes patients? In CKD, we do know that the type 1 patients, we are always concerned about it. You have heard from the previous talks as well about type 1 diabetes patients. So when we compare the type 1 and type 2 diabetes patients, well, more of the type 1 diabetes patients, if you look at the topmost row, more of the type 1 diabetes patients actually have daytime hypoglycemia during Ramadan period, significantly when compared to the type 2 diabetes patient, 64% of them compared to 25% in type 2. How about breaking of fast? Well, when it comes to breaking of fast, attending of emergency department, or getting admitted to hospital because of daytime hypoglycemia, there's no significant difference in the two groups. When it comes to hyperglycemia, similarly, there was also more increased proportion and clinically, statistically significant in type 1 diabetes patient compared to type 2 diabetes patient, at about twice the proportion, with 43, almost 44% in type 1 diabetes compared to 22% in type 2 diabetes who do have the hyperglycemia during the Ramadan period. So when it comes to evaluating the decision fast, why did he decide to proceed with fasting despite the high risk of fasting for CKD patient? Well, as the study was done during the pandemic period, it was actually evaluated whether their decision of fasting was related to the pandemic period, was whether that affected their decision to fast. Well, it did for quite a couple of them. In fact, it was significant, statistically significant percentage of type 1 diabetes patients that make decision to fast based on the fact that there was an epidemic ongoing at the point of time, and whether how many days they managed to fast was also affected by the period of the pandemic period as well. And if you compare when it comes to the type 1 diabetes patient, there is still a significant portion, about 74%, who managed to fast at least 3 weeks or more, 21 to 30 days. And similarly, for the type 2 diabetes patient, an even larger proportion, at about 80%, managed to fast 3 weeks or more during that period. Averaging out the mean days of fasting for the type 1 diabetes at 23, and for the type 2 diabetes at 25 days. So, and interestingly, quite a bit of proportion of these patients continue to fast after Ramadan. As you can see, about 1/5 of the diabetes type 1 patients fast after Ramadan period, and about 1/3 of the type 2 diabetes patient continue to fast after the Ramadan period, with no significant difference between the two. So, well, when it comes to comparing, we already compared to type 1 and type 2 diabetes patients, but how about those with CKD and without CKD? Well, it appears that it is definitely clinical significant when statistically significant that CKD patients have more hypoglycemia episode daytime because of CKD when compared to those without CKD. They do have more episodes of hypoglycemia, and not only that, their breaking of fast are more as statistically significant because of the diabetes-related illness when you compare with patients without CKD. So while CKD so when it comes to patients with and without CKD, there was significantly more CKD patients who have hypoglycemia and hyperglycemia, but there was also statistical significance of patients.
Excuse me, Dr. Suzyani.
Sorry again.
I think we are overshooting the time.
Oh, okay. Yeah,
please proceed.
Yeah. All right. So, so when it comes to the differences, I think I mentioned earlier, so I'm just going to skip this. So let's come to whether it is safe to fast. So, well, we know that for individuals with diabetes, both type 1 and type 2, they should discuss the intentions with their diabetes and renal specialists at least 3 months prior to Ramadan. They need to be monitored carefully if they have had transplant before by the transplant team before, during, and after Ramadan, and make adjustments to both their immunosuppressive and diabetes agents. For stages 3 and above, or on dialysis, fasting should be discouraged, and weekly reviews during Ramadan is necessary. They also need to stay hydrated outside of fasting periods and monitor the electrolytes and creatinines at various levels, as well as avoid foods with high potassium or phosphorus content, and do the safe fasting practices. So I think that's all. So just want to wish you a Ramadan Mubarak to all, and may bring us all blessings. So I end here. Thank you.
Thank you.
Thank you, Dr. Suzyani, for a very exhaustive and illuminating talk, and for highlighting both the sides of the coin, because the data is not very conclusive as we understand till now. So there are studies to prove that, okay, EGFR is maintained. Again, studies to prove that it may be progressing to renal failure. And again, your data on renal transplant patients and those on dialysis, that was also very helpful. So thank you so much. And do we have any questions, or if we are running out of time, I think we can go to the next topic. Do
I
we have
think,
any questions?
We are running late.
Yeah.
Ma'am, no, there are no questions at present.
Right.
Okay.
Dr. Suzanne, if there's something, we'll definitely WhatsApp to you, or
Thank
we'll
you.
send you a mail regarding any questions.
Thank you.
Thank you very much.
So much. Right.
Now over to Dr. Nilavani for the next topic.
Yeah, I think next is CVD by Dr. Apsia. So Dr. Amal, so
Yes,
CVD and fasting. And it is
I would like
interesting, very interesting, and which is a very common problem. I think it can help us to advise our patients. Please, Dr. Amal.
Now I thank you, Dr. Suzani ma'am. Now I would like to call upon Dr. Apsia Ruhi ma'am. Ma'am is consultant endocrinologist. She is currently working in Prime Health Care Group UAE, and ma'am has work experience from Hyderabad, India, Zuleika Hospital, Dubai, and ma'am has been an avid speaker in various national and international meetings, and she was also patient coordinator for a Sustain 6 trial from Hyderabad. Ma'am will be speaking on diabetes and cardiovascular disease. Is it safe to fast? Over to you, ma'am.
Dr. Apsia, just reminding the time.
Sure, ma'am.
Yeah, right.
Let me
Thank you.
share this.
Thank you.
Ma'am, is the share screen visible, ma'am?
Visible. It is visible. Visible, Apsia.
Yeah, sure. Okay, sure, ma'am. Something like Yeah, good afternoon, everyone. Thank you so much for giving me this opportunity. So let me start my presentation. Just a second, ma'am. I'm not able to see my screen.
Yeah, yeah.
Is that all better?
Some technical issue.
I mean, if there is any problem, you can share the.
We have your slides.
Yeah, we can play it
one
here
second.
only.
Yeah.
Bashir, can you please share Dr. Apsia's slides? I have sent it to the backend team. Bashir? The WhatsApp. Speak on it. Bashir, can you upload the slides? I've just sent them again to you. Backend team.
Yeah.
Yeah.
Yes.
Akshay, are you okay with this?
I'm not able to see the screen, ma'am. That's the issue. If you are able to see, I can continue, ma'am.
No, we cannot. 1 second. I'll just. Bashir, can you upload the slides? I've sent them to you again. Bashir, the phone level.
Yeah. Dr. Akshay, now this is visible. The slides are visible now. You can go ahead.
Sure. Thank you.
Yeah.
Now again, we are not able to see the screen. Slides. Shahla, till we sort out this issue, can we invite another speaker so that
Yeah, that's
Yeah.
fine.
Can
The
be-
next,
We
the
have.
next-
time can be
Yeah.
saved?
yeah,
Yes,
that will be
we can
better.
definitely do that.
Yeah.
That sounds sensible.
Sure,
Okay,
sure.
I'll just try to sort it at the back end and we take in the next.
Sure, sure, ma'am. Sure, ma'am. Thank you so much, ma'am. Yeah, sure, ma'am. Sorry.
No, not at all. I think Dr. Rai Chaudhary will go to the next session, next
Yeah,
topic. Yeah,
that will be
would
better.
like, yeah,
Ma'am, Dr. Rakesh Sai is the next speaker.
yeah. I
I think
think
Dr. Rakesh Sai is already logged in.
logged in, right?
Yeah.
Absolutely.
So, yeah. Can I request Dr. Rakesh Sai, if it's okay with you, can you start your presentation, please? Ma'am, I'll just call him in a minute.
Yeah, please. Another interesting
Amit?
topic.
Yeah,
Yeah,
Amit,
ma'am. Yes, ma'am.
Amit, if you can drive the
Ma'am.
discussion while I sort this out at the back end, please, so that the audience stays engaged.
Yeah.
If you and Neelavani ma'am and Dr. H. Chaudhary ma'am can drive the discussion, I'll till then get it sorted out.
Yeah.
Thanks.
Okay, ma'am.
Yeah,
Okay.
that will be better. Yeah.
Right. I think we had insightful discussions so far on the type 1 diabetes and the fasting and CKD and fasting and use of technology in the fasting. And now actually we were supposed to have the CVD, patients with CVD, should they go for fasting? So, but I think the important messages we could arrive on from the 3 discussions so far are type 1 diabetes, more than 18 years, and risk assessment has to be done. So like categorizing them into low and moderate and high risk. So if they are like, so definitely, so there was an ethical question, is it right for us to like allow the type 1 diabetes to go for the fasting? But definitely if they are at low risk and they are willing to fast, like to undergo the religious fasting, definitely it can be allowed, but with a supervision and with a proper pre-Ramadan education and all the inputs, like with maintenance of the glycemic status, monitoring status, maintaining hydration. So all these things are very, very important, so that they can go for a fasting. That is the message from the first speaker. And the second is the use of the technology in the fasting. So definitely definitely technology does help because with respect to the monitoring, so that we can predict the risk of hypoglycemia in the coming few minutes. So low sustained glucose monitors, and also definitely they help. And so as Dr. Shaktivel was discussing on the deep learning and machine learning and use of artificial intelligence and the various monitors, like the invasive, anyway, it's still there, but minimally invasive or non-invasive technologies to monitor, so that they can help the physician also to make, and with the help of teleconsultations, we can allow even the like moderate risk patients also, if they are voluntarily willing to go for the fasting. I think that's what I could understand. And another CKD, again, the little controversial data with respect to the CKD, less than, I think many of the studies have shown no decrease in the EGFR, because dehydration is one of the important like in the sense risk factor for them to have a change in the
Dr. Saha is ready, I think.
Yeah. Ready, sir
Yeah.
is ready. Yes.
Rakesh
So
sir
we
is
can
ready.
go ahead.
Yeah.
Very nice. So
Yeah,
metabolic,
I'm ready. As soon as
metabolic
you say
benefit.
okay, I'll present. Yeah.
Right.
Ready, sir.
Dr. Rakesh, please go ahead. Metabolic benefit of Ramadan, myth or reality? Dr. Rakesh Sahai. So current president of National RSSDI and president of CEPHIS, and past president of ESI, with so many feathers in his cap. So everyone knows him nationally and internationally. Over to you, Dr. Rakesh.
Yeah. So thank you, Dr. Neelavani, for the kind words of introduction. At the outset, I should congratulate our president, Dr. Jabbar, for organizing this series of webinars on Ramadan and its effects and carrying out, and diabetes, particularly how diabetes should be managed effectively in Ramadan for the benefit of all the healthcare providers, and so that we provide the best benefit to our patients. So, and also Dr. Shaila, who has taken special efforts to organize this, getting together all the stars who are other than me. I am not a star, but all the other stars who have been speaking in this meeting, and Dr. Hamid also has put in a lot of effort in organizing this program. So my topic that is given to me is about metabolic benefits of Ramadan. So I think basically we had a lot of discussion in the last session. Although I have seen the program, and Dr. Beatrice has spoken about the physiology of fasting. She has spoken about how intermittent fasting has shown several benefits. So just to take you through that, we know that when you're looking at the fed state, what happens, that it's mainly a state where insulin is in excess and insulin is produced. Insulin is driving the metabolism of glucose. It's driving the uptake of glucose into the hepatic, into the muscle cells, into the liver cells, and going towards, and everything is going towards storage and glycogen synthesis. And in the so this is what happens in the fed state, as you can see, in the 4 to 6 hours following the meal intake. And during fasting, the reverse happens, where we are saying that insulin secretion is significantly suppressed, the glucagon levels are high, and the counter-regulatory hormones stimulate the glycogenolysis and gluconeogenesis in the liver, and maintain the glucose in the physiological range, so as to provide glucose continuously for the brain, and also increase the production of other metabolites for the various other tissues to carry on their activities. So this is what happens during the fasting stage. This metabolic switch in glucose metabolism occurs, whereby the liver converts the fatty acids to ketones, the beta hydroxybutyrate and acetoacetate, which are used as alternative source of fuel for the brain when the fasting is prolonged. And this also serves as a fuel for the brain, the muscle, erythrocytes, and other tissues, when the fasting is prolonged beyond the expected time of about 14 to 16 hours. So we know this again illustrates what happens in a healthy individual, how the metabolic switch occurs when the fasting is prolonged beyond a particular period of time. And today we are all speaking about the benefits of intermittent fasting, and and we are trying to see how the benefits happen. And as I was just mentioning about the metabolic switch, which happens when the brain starts using alternative fuel, the muscles also start utilizing the alternative fuel, particularly the ketone bodies, and the liver increases the insulin sensitivity, reduces the lipid accumulation in the liver, reduces intestines, and all the other tissues show physiological benefits with fasting. So we are clearly seeing that amongst the various ways of weight reduction, we have shown that time restricted eating or intermittent fasting, as we call it, has shown to have significant metabolic benefits. And we could, if you actually extrapolate this to the fasting during Ramadan, it can be considered to be a type of intermittent fasting, because that is what is happening. There are 14 to 16 hours of no calorie intake, and then you have the rest of the time and there is calorie intake. But this is beyond that. It is not just this intermittent fasting, because we have seen, because in Ramadan it is also the timing of the meal is changed. The sleep food in the sleep quality, the sleep timings, everything else changes. The social interactions, everything changes. So those are beyond what we see with intermittent fasting. But clearly what we have seen is that the health benefits of intermittent fasting have been shown in various studies, where we see that there is a well-sustained, there are several benefits seen with intermittent fasting, whether you're looking at metabolic benefits, whether you're looking at vascular benefits, whether you're looking at effects on the inflammatory pathways. In all these pathways, we have seen that there are several benefits of intermittent fasting. And so many of these benefits have also been shown in different studies which have been done in people with during the Ramadan month also. And these benefits have been shown with various forms, various types of therapy that are used for managing diabetes. Now, in type 2 diabetes, when you say there is, because what we're saying is that I was referring to in the previous few slides about intermittent fasting in a non-diabetic individual. In diabetes, the milieu is little different, with inflammatory pathways being active, oxidative stress being active, and all these things are significantly elevated in people with diabetes, and intermittent fasting continues to provide those benefits in these individuals with diabetes also. And so the liver maintains. So in fasting, what we see is the liver maintains the blood glucose levels by regulating the metabolic pathways, such as increasing gluconeogenesis, as well as upregulating the activity of two restriction enzymes, namely phosphoenol pyruvate kinase and glucose 6-phosphate dehydrogenase, to regenerate glucose and maintain the blood glucose levels. So, and what we have seen is that if you look at various studies which have been done in the month of Ramadan, on individuals with diabetes who have been fasting during the month of Ramadan, we find that there have been significant improvements in the HbA1c levels. Across different studies, we have seen that there is a significant improvement in the HbA1c level. On the average, about 0.5% reduction in HbA1c levels have been seen in different studies. A 2012 meta-analysis of 35 studies showed a 1.24 kg weight reduction, and during the month of Ramadan fasting, and regaining of mean weight of about 0.72 kgs during the 2 weeks following Ramadan. Although there has been a significant reduction in fat percentage in overweight and obese people, leading to weight loss, it is not a universal outcome that is seen, and weight change during Ramadan shows a wide inter-individual variability. And so another meta-analysis of 30 cohort studies, which was published in 2013, also showed a decrease in LDL levels and fasting glucose levels after Ramadan fasting in healthy male and females compared to their levels prior to Ramadan. And a significant increase in HDL cholesterol was also seen in females, and a decrease in total cholesterol and triglycerides was seen in males. So clearly there are several metabolic benefits which have been shown in different studies conducted during the month of Ramadan. And what we also say is that, you know, the other benefits that happen with intermittent fasting, although they have not been clearly studied in Ramadan in many of the studies, but you could extrapolate that many of these benefits may be happening even in people with diabetes who fast during Ramadan. The experimental results have shown in the intermittent fasting mediates the increase in VEGF levels in white fat and M2 macrophages. The M2 macrophages are the ones which lead to browning of fat. So they are activated, and there is increased thermogenesis and reduction in obesity. All this happening because of the switch which is happening with that duration of fast which happens during intermittent fasting. And several other benefits also shown. Cognitive benefits are also seen during fasting. In type 2 diabetes, we can see that the cognitive dysfunction which normally occurs in diabetes is ameliorated to some extent by improvements in the mitochondrial biogenesis and energy metabolism, gene expression. All these things improve in people with diabetes, and these neuro cognitive disturbances which are seen in many individuals are improved with fasting. And there is also interaction with the gut microbiota. The gut microbiota, as we know, has emerged as an integral role player in the progression of chronic diseases such as diabetes or obesity. And although specific effects of Ramadan fasting on gut microbiota has not been studied extensively, but a small pilot study from Turkey revealed that gut microbiomes were significantly enriched after the end of Ramadan fasting. So clearly we are seeing that there are several different benefits. There are benefits on the adipokines also. As you can see in these studies, there was some of the studies by Dr. Hasnain also have shown that there is increased resting metabolic rate, and total daily energy expenditure was recorded. And some studies have recorded lowering of inflammatory cytokines like CRP, IL-6, TNF-alpha, adiponectin, leptin, and adipokines, which are secreted by the adipocytes, and some improvement in the adiponectin levels also have been shown in different studies. Although these have been small studies, small number of patients studied, and but clearly some benefits have been shown. And if you look at the effect on diabetic complications, some of these have been studied in mouse models of fasting. They have shown alleviation of diabetic retinopathy by remodeling of the intestinal flora, prolonged survival, reduced diabetic retinopathy endpoints with unchanged glycosylated hemoglobin, reduced TNF-alpha mRNA levels in the retina. All these have been shown in experimental models. So there is scope for studying these in people who fast during the Ramadan, whether there are some improvements in the retinal complications. We just heard Professor Susie speaking about the effect of fasting on the renal parameters, and although there was no data, I mean no study which showed any significant worsening of renal parameters, and most of them showed that people could fast even with moderate degrees of mild to moderate renal impairments. They could fast without any significant problem. And the same was what we heard about type 1 diabetics, that once they there's not always a no for type 1 diabetics also, as earlier we used to think, but now with the availability of the new insulin analogs, which are more safer, we have data with all these insulin analogs showing to be quite safe, making fasting quite safe even in type 1. There's some benefits on cancer cells also. I'll not go into details of that, but nevertheless, important to say that there are some beneficial effects even on cancer cells with fasting, and also so all these effects are mediated through different pathways, which I'll not go into details of that. This is summarizing that. The pathways involved, the mTOR pathway, the AMP kinase pathway. All these pathways are important, and they are favorably influenced by fasting. So fasting has several effects. the benefits that can accrue are in terms of improvement in weight, improvement in body composition, increase in energy expenditure, decrease in energy intake, can thereby lead to weight reduction. Cardiometabolic risk factors are favorably affected. Glycemic control is better. Aging and cognitive functions also improve favorably with fasting. So this is what are the various benefits which are summarized here in this cartoon, which happen with fasting. Now there can be concerns also. The topic is because whether all these benefits are a hype or really a reality. So what we see is that there are concerns also. There is a higher risk of hypoglycemia, as we know that the metabolic switch which happens when people are fasting, particularly when we said that in some parts of the world when the fasting duration may be longer, in some seasons, like it may be as long as 16 to 18 hours also. So there, in such places, when the metabolic switch is delayed, then they can actually potentially go into hypoglycemia. And even so, this is particularly true in the last few hours of fasting, which was again highlighted by the previous speakers when they were speaking about the risks in type 1 diabetes. So similarly, those things and hypergluconemia, which happens in type 2 diabetes as a compensatory mechanism, can actually contribute to sometimes to a very severe hyperglycemia, and that can be a adverse effect. And similarly, you can in type 1 diabetics also, what happens is that there could be significant hypergluconemia leading to augmented gluconeogenesis and ketogenesis, which lead to significant hyperglycemia. And all these are the problems that can happen. Similarly, on the other side, you have the risk of hypoglycemia, and the other risks that happen is because of dehydration and thrombosis that were also discussed in the previous presentations. So these are some of the risks which can be happen while we're looking at all the benefits. Sometimes these risks have to be we have to be carefully watching out for these and avoiding these risks. And so if you look at some of the studies which have shown that while many studies have shown benefit, there are some studies which have shown some not so great impact. I mean, in the sense that there have been some adverse effects of fasting also. These are, again, what we need to understand is that these happen because the change in the sleeping pattern and the social environment. If people are all seeing that the feasting that happens after the fasting is sort of if we educate our patients to see that they moderate that, then I think and also how they can safely fast during with making adjustments in their medications. All these can make them get the metabolic benefits without going into problems. So I think these are some of the things that we need to keep in mind. I think I will and also the other point that I would say is that sometimes the suhoor meals may happen very early. Somebody may take a very early suhoor meal, pre-dawn, and have a longer duration of fasting. The effect on the sleep time because of the changes in circadian rhythmicity may also have an adverse impact sometimes. So these are some things which have to be looked into and individualized. Some people who may have some issues have to be properly educated. And in general, what we see is that we should educate our patients so as to see that these potential metabolic adverse events do not happen, and we are able to provide a education to ensure that they are able to fast without safely during the period of Ramadan. So I have just put down these points which we should all see that we followed, so as to encourage to see that our patients are able to fast safely, and that is providing them a Ramadan specific nutrition plan, which was already discussed earlier. The plate model can be a useful model to explain how the food intake should be adjusted during the month of Ramadan, and Ramadan focused education provided in terms of the timing of the meals and how the adequate hydration and the need for adjustment in medication, which has to be told to the patients earlier so that they can do it from the start of Ramadan. And emphasizing the need for monitoring of blood glucose levels during the fasting hours is again a very important step that has to be taken to see that they do not go into any metabolic problems while getting the metabolic benefits, and awareness of the indications where they should break a fast. What should be the scenarios where they should certainly break a fast and not delay that and not continue with the fast so as to avoid any metabolic problems that may happen. So I think I would conclude by saying that Ramadan fasting entails, provides many biological and metabolic benefits, and it can be considered as a, if you're looking at a non-pharmacological way of extending life expectancy, improving the quality of life, even in older people who are fasting. Its health promoting mechanisms have been studied extensively, and they have been documented extensively. But there can be some maladaptations in some individuals. We should try to mitigate these potential negative effects by adequate education, and there is need for more research towards understanding these mechanisms, and so that our patients are able to fast safely. With that, I'll conclude. I thank you all for inviting me to be here.
Thank you, Dr. Sahai. That was a beautiful talk on the metabolic benefits of fasting. Just one point I would like to discuss, that is Ramadan fasting is definitely a form of intermittent fasting, but there are a few differences also, like in the form that, the diet pattern. Actually, at iftar, there is a tendency to go for very high fat and high sugary foods. That is one thing. Second thing is that exercise level goes down during the Ramadan fasting, naturally, because the fasting hours are prolonged during the daytime. And moreover, because of the change in the timings of the meals, there's a disturbance of the circadian rhythm also, with the count regulatory hormones going up and insulin resistance. So I think that if it is definitely a very good opportunity for going for good metabolic control, but for that, we have to be conscious of the diet we are consuming, what amount of exercise we are doing, when and where. I think that way we would be even more benefited. Your points, your views.
Yeah, I think your point is well taken. That is exactly what I was trying to highlight in my entire presentation, was that, while fasting provides many metabolic benefits, sometimes, we do not see the same amount of benefit happening in all our patients. That is because many of them are, or at least some of them at least, are not able to adjust the food habits in such a way, that the food consumed at iftar, at the break of fast, should be, we should be able to educate our patients so as to, avoid too much of sugary food, eat more of, a healthy diet at that period. And, and then during the month of Ramadan, there is this evening prayers, Taraweeh prayers, where a lot of exercise, also physical activity, increases during that period. And that actually provides for that loss of physical activity during the day. And so I think all in all, there is a sort of what I am trying to say is that we should be able to educate our patients so as to get the positive benefits and avoid some of the problems that happen because of a maladaptation that happens. Because, although there are several good points, but sometimes it's stretched in a direction which, people tend to eat more of the sugary foods and all these foods during the evening, and lose out on the benefits that happen during fasting. Dr. Hamid was adding some comments. Dr. Hamid, your comments.
Yes, definitely, fully agree with you. Total amount of energy intake is very important, what the patient is eating. The essence of fasting is that we should decline the amount of energy and food which we are taking. But because of the feasting, which you have told that which happens at every day at the time of ending the roza, that is the iftar time. So at that time, if the care is not taken, then definitely the benefits, in fact, not only physical and mental and spiritual benefits will also will not be availed if the patient is not you can say restricting the amount of diet and amount of energy which the patient is taking. So that's a very important thing. The total amount of energy and food consumed during 24 hours. If it is more, then definitely some patient definitely going to gain weight. That happens many a times. So definitely amount of food and the content of food is very important, sir.
And in many of the studies which you have done with whether with the GLP-1 analogs, with the SGLT2 inhibitors recently, or with the DPP-4 inhibitors, all of them have shown some metabolic benefit at the end of the 1 month of fasting and the use of these agents. So I think there is potential for significant benefit. I think, and the purpose of these webinars that we're doing is mainly to spread this awareness and improve the the benefits that people
Outcome, yes. Improve the outcome. Yes.
outcomes of fasting.
Thank you. Thank you so much.
Thank you.
So thank you once again. Thank you,
Thank
Dr.
you.
Nila
Thank
and
you. Thank
Dr.
you.
Jabbar and Dr. Hamid
Thank
for
you, sir.
giving me this opportunity.
Thank you. Dr. Apsia, ready?
Now I would like to call Dr. Tejal Lathia ma'am. Ma'am is consultant endocrinologist at Apollo and Fortis Hospital, Navi Mumbai. Ma'am has around 50 peer-reviewed publications, and ma'am is currently doing research on exploring the relation between mothers and daughters with PCOS in the context of hirsutism. Ma'am will be talking upon Ramadan, a harbinger of lifestyle change. Over to you, ma'am.
Yeah, so actually, after listening to Dr. Sahai's talk, I'm thinking, is there anything left for me to talk? Because most of my slides are going to overlap with Dr. Sahai. So I will keep it very short because anyway, I think, are running behind time. So let me start my talk. I'll just quickly share my slides. Where is the share button? Yeah, okay. So only 1 minute, please. Thank you so much. And yes. So at the outset, thank you everybody, Dr. Ashraf and the entire team, Dr. Shaila Sheikh, for the kind introduction. And I am going to speak about Ramadan. Can it be a harbinger of lifestyle change and weight loss? So I think this is the only slide that probably I should talk about because Dr. Sahai has covered almost everything. And so this is the traditional societal, all the fasting that occurs in different religions across the world. So one of which is, of course, Ramadan, or in Islam. Jains have a lot of fasting, Buddhists have fasting. And of course, there are non-religious practices like time-restricted eating and alternate day fasting. This is on a very light note. I'm a Jain. So Jains are famous for their fasting, and I can claim that Jains do the most serious fasts in the world. So we do something which is called as Atthai, and humko aise lagta hai ki that is real fasting, where we fast for 8 days and only warm boiled water is allowed. Boiled cooled water is allowed. And then the fast is broken on the 9th day in the morning with some boiled moong and the water of that boiled moong. So they fast throughout the day, throughout the night, but only water is allowed. And Jainism is traditionally a very strict religion. And often what happens is that many of my relatives do it. I have never done it. And what I can see is that they lose a lot of weight. So they would even lose up to 10 to 15 kilos. But exactly what Dr. Ashraf, Dr. Rai Chaudhary, and Dr. Sahai were talking about is, unfortunately, all of the weight comes back once the fast is over. So what I would like to highlight is that though Ramadan can be an opportunity for lifestyle changes and weight loss, but often because of our basic human tendency to go back wherever we started from, we often lose this window of time that we can use to lose weight. Christians also fast. They have the Lent, which is for 40 days and 40 nights, and they don't touch alcohol, they don't touch meat, and they also do their own type of fasting. Buddhism is a relatively milder religion. So I did the Vipassana meditation, which is a course based on the Buddhist philosophy of meditation. And there, breakfast was 4 o'clock, lunch was 11 o'clock, and the last meal of the day was at 3 o'clock or 4 o'clock in the afternoon, after which there was no food that was allowed, no tea, no coffee, and only water could be consumed. Unfortunately, when I went for this program, I did not lose any weight. The reason is it's a 10-day course. And the reason I didn't lose any weight is because the food was delicious. And I actually ended up eating more than I would have eaten at home. And that is why it was not successful. So what I'm trying to say when I'm putting this slide up is that though religious practices were initially intended for good health, and the entire philosophy of Ramadan is about abstinence, not only from food, but also from negative thoughts. It's a time to cleanse yourself spiritually, to reconnect with God, ask for forgiveness, and is basically an opportunity for spiritual growth. But human beings, what they are, the Jain fasts are also the same. We do it in the month of Bhajushan. Is also the same, is that we often tend to, one, not exercise during periods of fasting. And in the kind of fast that I was talking about, which I followed in the Vipassana meditation, there was no caloric control. So in spite of eating only 2 or 3 times a day, time restricted eating, because the calories I was consuming was very high and there was no exercise, I actually did not lose any weight. So going ahead from that, I'm not going to talk about this pathophysiology because luckily I caught Dr. Rakesh Sahai's talk. And the only thing that I would like to highlight is at the bottom. So in the short-term benefits of intermittent fasting, which is Ramadan is a type of intermittent fasting, is there is a benefit for weight loss, there is reduction of waist circumference and optimization of body fat. But what it also can do, intermittent fasting, even for a short period of time, can have long-term effects where it reduces oxidative stress, reduces cellular inflammation, increases autophagy of disease cells, and can probably give a reduced incidence of long-term metabolic conditions. So as we spoke, that there's an effect on metabolic health and significant reductions in weight. However, this is one slide that I would talk to. There seems to be something about intermittent fasting which goes on in Ramadan or maybe in other religious practices, is that many times, even if it's a calorie restricted diet or a eucaloric regimen, not like me where I ate more than normal, but eucaloric versus caloric restricted diet, somehow there seems to be a physiological benefit in both groups, independent of the reduced calorie intake. Now, some of the hypotheses are that when you have a eucaloric intermittent fasting for, say, 30 days, there's improvement in proteomic signatures, upregulation of proteins related to immune system regulation and DNA repair in short-term studies, which show that there can be reduction in chronic inflammation, better immunity, and can have a long-term impact. So it's not only the caloric restriction which comes along with time restriction, but even in eucaloric intermittent fasting, there can be benefits. There's one more thing, which is the circadian rhythm. So we all know that there are circadian rhythms for cortisol, circadian rhythms for insulin and blood glucose levels. So there also could be the possibility of a time of day variation and the metabolic response to calorie consumption. When I eat food in the day or when I eat food in the night, independent of the amount I eat, is there any difference? And one of the hypotheses is that in intermittent fasting, when you eat during that time of, say, 12 to 8 o'clock, there's an increase in adiponectin following this time restricted eating. So eating in a short duration of time can have some impact on the production of adiponectin, which we all know is a positive beneficial molecule in obesity. And in physically active participants, in patients who do this time restricted eating, there can be increased levels of adiponectin and a benefit. However, the single most important thing about intermittent fasting is if the diets need to be sustainable, which means that once you do a bout of intermittent fasting and you lose X amount of weight, you also need to continue to do that. So in one study, what they saw is that even on days when people were not restricting their eating, means they were allowed to eat throughout the day, they still tended to take less amount of calories on the day that they were allowed to eat for a longer period of time, which could have contributed to the weight loss. But if there is one takeaway that I can give you from this presentation today of mine, is that what I think fasting and time restricted eating does, it makes us aware of our eating habits. It makes us aware of our cues for hunger, and it helps us to improve our eating behaviors even on unrestricted days. A lot of times, because human beings are exposed to food throughout the day and also throughout the night, many times people who work in shifts tend to eat large meals, in the night. So what a period of fasting does, to my mind, and this is about behavior, not about the pathophysiology, is that it makes us more aware of the times of day when we tend to be more hungry. Is it really hunger or is it thirst? How much food do I need to feel satiated? So usually after a long period of fast, when you actually sit down to eat, probably because of the mild amount of ketosis that happens, you actually don't end up eating much, and even a small quantity of food is enough to fill your stomach. However, because we're so conditioned to eating a particular quantity of food, sometimes even if we are satiated, we continue to eat. So I think one of the best results of intermittent fasting or even of Ramadan fasting, a thing that we can leverage is that it can help us to become aware of our eating habits, aware of our hunger cues, aware of our satiety cues, and help us to improve our eating behaviors in the long term. And what Madam Dr. Ray Chaudhary said, I completely concur with her, I mean, which was part of my presentation. One of the reasons why Ramadan may not be enough alone to cause weight loss is because it is unaccompanied by exercise regimens, because fasting without water is extremely difficult and somebody cannot exercise. So that's one of the main reasons. And of course, the second main reason is that, like what human beings do across every religion in the world, is we always use our religious practices to somehow become convenient, and then we end up eating a lot of food. In fact, my husband becomes more happy during Ramadan than many Muslims, because now he gets invited to all his friends' place to eat biryani, and he's extremely, extremely happy during this time. So Ramadan is the absence of eating and drinking from sunrise to sunset. The fast could range between 9 to 22 hours per day. And as I said, is not only a fasting of the senses, like your mouth, but also a fasting of the mind, where we shun negative thoughts and self-reflect, and it helps us to have self-control. It shows a human being how much control they have over their mind, and they can exercise control over their mind, and also a time for forgiveness. So it's a culturally determined example of intermittent fasting, and it's an opportunity for us to look at the effects of fasting in a real world setting. But as we discussed in the previous slides, there is a modest weight loss and a modest improvement in glycemic control. The reason being exactly this, that what is the energy intake in the non-fasting period, and whether the person under or overcompensates for the lack of energy intake during the fasting period. So if somebody is going to eat high calorie food in the time restricted period and takes more energy than is needed, then obviously weight loss is not going to happen. So that is why there is a very modest weight loss after Ramadan, and this weight loss is not really sustained. And up to 2 to 6 weeks post Ramadan, this weight loss from minus 1.25 to minus 1.5 can become as low as minus 0.3 kgs. So though Ramadan and non-Ramadan intermittent fasting is effective for fat mass and body weight loss, unfortunately, it is often not successful. I'm going to skip these slides because I think Dr. Rakesh has taken most of this. This is just a last 1 or 2 slides I'll talk about. So most of the weight loss in intermittent fasting is weight loss, and participants following the intermittent fasting did regain some weight during follow-up after intervention, although the average body weight remains statistically significantly lower than baseline levels. So if we continue the time restricted eating from about, say, 4 weeks and extend it further, then yes, there is a sustained weight loss. When we stop, there is some weight regain, and most of the weight regain occurs after 6 months. And even though there is some weight regain, it may not go back to the pre-intermittent fasting levels. The practical length of a fast needs to be 16 hours, and weight loss doubled. Again, Dr. Rai Chaudhary, to answer your question, weight loss doubles if exercise is added to intermittent fasting. But one of the biggest challenges is dropout, and most of the intermittent fasting studies are very short, usually 6 weeks, 12 weeks. I think there are only 1 or 2 studies which I could find were up to 1 year. And weight loss was directly related to the number of days in the week that the person actually stuck to the intermittent fasting. So many times people are not able to sustain intermittent fasting, and if they're cheating, then the weight loss obviously will not be commensurate. Most of the time, hunger levels remain stable or decrease during intermittent fasting, mostly because of the mild ketosis that happens. So intermittent fasting is promising. Most of the studies are small and of short duration, even in Ramadan. And if we really want intermittent fasting to help us achieve weight loss, even in Ramadan, 2-3 things that we need to focus on. One is the amount of calories we consume during that time restricted part. Do we consume more calories than usual? Is there any exercise accompanying it? And what is the behavior that we continue to take away after the Ramadan is over? And whatever diet we have should be a sustainable one. So water may not be sustainable in the long term, but definitely time restricted eating, if continued for a longer period of time with a eucaloric diet or a hypocaloric diet, can result in good weight loss. And I'm sure that most people start Ramadan thinking that, okay, now this time I'm going to do it really properly and I'm going to show everybody and I'm going to lose weight. But often that is not what happens, as with most religious fasting. I hope there are no Maharashtrians here, but even for my audience, so I'm married to a Maharashtrian, so I'm taking some liberty. I'm a Gujarati Jain who is the strict fasting people. So when a Jain person sees a Maharashtrian person fasting, we often feel like they're not fasting because they often eat more on the day that they fast than they eat on the day that they don't fast, and you eat all carbohydrate laden deep fried foods. I often laugh at my family, my Maharashtrian side of the family, कि तुम लोग को तो fast करना आता ही नहीं, आपको जैन से सीखना चाहिए कि fast क्या होता है. Thank you so much.
Thank you, Tejal.
I
Very
hope
nice.
I'm able to catch up to time as well.
Yeah. I think, we are running short of time.
Hi, Dr. Niliveni. I didn't see you
Hi,
there.
hi. Nice talk, as usual.
I kept it short because Dr. Syed covered everything. So most of my slides were redundant.
Important points have been given to the audience, like by you as well as by Dr. Rakesh. So very important. I think it's very important in the sense fasting in the sense calorie restriction is important apart from other aspects. So I think because of the short of time, if there are no questions, we will move on to the next.
I just had a very short question for Dr. Tejal. The general opinion is there would be hunger pangs, but from your discourse, it seemed that is not true. So is that the reason is because of the mild ketosis? Is that so?
I think so, but can I please just do a very practical point here? So I'm somebody who cannot do intermittent fasting. I have a family history of diabetes. I have insulin resistance, and somehow I am not able to do intermittent fasting. I feel hungry throughout the day. And I remember once, for some reason, I fasted, and I'm telling you, ma'am, I drank tea like every hour for the entire 24 hours because I could not bear the fasting. So I think it's also different for different people. And one of my other colleagues also did intermittent fasting. And what they realized is that, when it used to come to the fag end of the fasting period, he started getting angry, started getting cranky. He would lose his temper. He would kind of crash and not be very happy about it. So I also think, like with everything else in life, intermittent fasting is also individualized. Some people do well with intermittent fasting. Some don't do well with intermittent fasting. But yes, probably the mild ketosis, which is supposed to happen, which somehow never happened for me, is supposed to blunt the appetite, and it's supposed to blunt the hunger cravings, and is supposed to help the person remain fasting.
Yeah. On a personal note, when I fast on religious occasions, I do get hunger pangs. So
Absolutely. I feel very hungry. I am not able to fast. And at the same time, my husband, he's an orthopedic surgeon. I cannot tell you, he eats breakfast at 7 in the morning and his next meal will be at 11 p.m. in the night. He does major knee replacements. He does hip replacements, spines throughout the day. He's standing for 8 hours at a stretch, but he doesn't feel hungry. He doesn't lose his cool, and he comes back home and eats at 11 o'clock in the night. So I don't know how he sustains the fasting. So we're all human beings at the end of the day.
No, it all depends how you tune your brain, how you have adjusted your system.
No, I disagree. I cannot control it.
Yeah.
No, that's what, like each individual is different. Like even I have a good amount of breakfast in the morning. I stay till 5 o'clock in the evening. So yeah.
You have good sleep.
It all depends. It all depends. I think we will move on
Thank
to
you so much.
yeah.
Yes, ma'am.
Thank you.
Apsia, ready? Your problem is solved out?
Sure, ma'am. Is the screen visible, ma'am? Yes, ma'am.
Yeah.
Is the screen visible?
Yeah.
Yes.
Yeah, sure.
Go
So
ahead.
let me say thank you so
Yes.
much for
Yeah,
giving me
yeah.
this opportunity. Thank
Please,
you, ma'am.
again, we are running short
So
of time.
my topic
Apsia.
is it safe
So-
to fast?
Running
Sure,
short of
ma'am.
time.
I'll just make it
Yeah,
very
be to the
fast.
point.
So is it safe to fast? Sure, ma'am. So today we are going to discuss, is it safe to fast in Ramadan with diabetics? So here we are going to discuss, this has been already discussed by the previous lectures, but here in a summary, in MENA, we call it as Middle East and North Africa. In this MENA group, we have 19.8, nearly 20% of the people who are Muslims who go for, but when coming to the Asia Pacific overall region, there are 61% people proportion. So this has already been discussed in the previous lectures, what happens during fasting and Ramadan. So I would just like, and this risk stratification has already been discussed based on the 14 points. We categorize the people as high risk. And once these are the risk factors during the Ramadan months, that there is the risk of diabetic ketoacidosis, hypoglycemia, hyperglycemia, and dehydration, which are the expected risk factors because of the fasting during Ramadan. So, in the EPIDIA study, which has been done in the during Ramadan period on the people, it has been found that there is 0.14% risk of severe hypoglycemia, but there is 3.2-fold increase in the hyperglycemia when compared to hypo. So overall, there is in type 1 diabetic people, there is 3-fold increase in the hyperglycemia, whereas in type 2 diabetic people, there is 5-fold increase in hyperglycemia when compared to hypo. So when coming to the cardiac, which is my specific topic, so there are some studies which have been done on cardiac patients during Ramadan. So these studies, which has been done by Salam et al., over 4,157 patients, it has been concluded these patients have been admitted in hospitals for acute heart failure. So it has been found that there is no significant difference between hospitalizations during Ramadan as well as outside Ramadan, which is approximately 52% and 48% respectively. So the second trial, actually this trial is done in 7 countries in the Middle East, which is a prospective observational study. The second study done in 2018, which is the latest study, it has been shown that 2 out of 249 to 227 people, which is a prospective study of 54 years age people, which is a mean age for this study, there was not associated with the worsening of the symptoms during hospitalization. So the trial, which has been done by Swadi et al., in 2006, in 2160 people, it also shows that there is no significant difference in the number of hospitalizations between pre-Ramadan, Ramadan, and post-Ramadan. So a multi-center study has been conducted in the Gulf region, which has found that there is no difference in proportion of patients who were hospitalized for heart failure during and after outside Ramadan. Similarly, one more study has been done with heart failure where 18 had worsening symptoms but this worsening, they have concluded that it was because of the non-compliance with the dietary advice and medications. So there are few more studies which have been done with diabetic people, Ramadan, as well as with acute coronary syndrome. So in the first study, which has been Pasha et al. In 86 people, which is a prospective observational study in Saudi Arabia, there was no significant change which has been found. As well as the same Kafaji et al., Sawaidi et al., and Movaisi et al., it has been found that there is no significant difference in the proportion of people, the complications when compared to the pre-Ramadan as well as post-Ramadan. So these are the cardiac related issues. When coming to the studies in the stroke, we have Asi et al., Sekel et al., and Zimhani and Asdeen et al. In these, if we go for the Asi et al. Group, there is 220 sample was there, which is a longitudinal cross-sectional study, which was done in Egypt. This was also found that there is no significant difference. But in the study of Zimhani et al., there has been statistically significant association between the stroke incidence has been found increased. So it is a conflict whether the patients on stroke should be going ahead with the fasting or not, because some studies, because all of them are observational studies, some are prospective and some are retrospective, some shows that there is benefit, some shows that there is no significant difference. So when coming to the considerations and recommendations which has been done, this is by the DAR global study. It is recommended that all people with diabetes and pre-existing cardiovascular disease are seeking to fast during Ramadan should receive a risk assessment score based on this risk stratification system, and who are having high risk should be advised not to fast. So this is a consensus done by the Turkish Society for the Ramadan fasting people with cardiovascular diseases. In the study, they have confirmed that when coming to the cardiovascular prevention, the patients, so we have a high risk, the green symbol indicates that these people can go ahead with fasting. The yellow with some risk factor, the person who has red, that is the fasting should be avoided in patients with CKD accompanied by CAD because of the risk of increased kidney injury and thrombosis. Also, if the patient has recent PCI done within the last 3 months, also should be avoiding the fasting because of the increased dehydration can be having the risk of stent thrombosis. And if there is any recent acute coronary syndrome, again within the last 3 months, yes, they should not be going ahead with the fasting. More than 3 months, they can go ahead with fasting with taking proper precautions. When coming to the heart failure, the patients with heart failure who have been on medications, they like and also have associated hypernatremia, hypokalemia with fluid issues should not go ahead with fasting. And the persons who have with hypertension who are uncontrolled as well as who are on diuretics should be recommended not to go ahead with fasting. So they also have summarized that in the cardiovascular diseases, the persons who have controlled hypertension, stable angina, heart failure with mild to moderate valvular disease, mild to moderate pulmonary hypertension, atrial fibrillation and SVT. These are the category people who can go ahead with fasting with taking proper precautions. When coming to the remaining, like recent MI within the last 3 months, recent PCA in the last 3 months, heart failure of class 4, heart failure which has been with decompensation in the last 6 months, severe pulmonary hypertension, severe ARMR, all the valvular diseases, who have long QT or Brugada syndrome, HOCM, and uncontrolled ventricular arrhythmias and uncontrolled hypertension should not go ahead with fasting. So these are the key factors which has been discussed in the last study. So whenever we have the person have decided that he will go ahead with fasting, the only thing 6 steps to be taken. When to break the fast, they should know where is the risk stratification, how to monitor fluids and exercise. This has already been discussed in the previous. So when to break the fast, this has already been discussed where less than 70, more than 300 and symptoms of either hypo or hyper. This is the SMBG where if it is a controlled person with controlled diabetes, only 2 times monitoring is enough. If it's uncontrolled, 7 times monitoring is required. And coming to this, along with this lifestyle modification as well as the medications management is also very important. So the metformin, the GLP-1 analogs, DPP-4 and SGLT2 doesn't require any dose modification. Metformin actually from 3 times should be shifted to 2 times. And thiazolidine depending on the, if patient is taking food, yeah, it will be given only with the iftar. And these are the insulin regimens which has been discussed in the previous slides. And these are the 10 principles of the Ramadan nutritional plan. In the last discussion, actually, we were going ahead with some after Ramadan, like in this after having a suhoor, we will be having, especially we will be having the hunger. This in this DAR study, it has been confirmed that if we are taking complex carbohydrates during the early morning suhoor, and if you are taking the simple carbs during iftar, this is recommended one so that we can avoid the hypos and hypers. And these references are from the IDF DAR as well as from the Turkish consensus study of cardiology. Thank you.
Thank you, Dr. Apsia, for a very lucid and a short talk, where you have given clear-cut messages with respect to where a person with CVD, cardiovascular disease, should go and should not go, low risk and high risk categories. You have clearly given this thing. And even if we allow also again with proper pre-Ramadan education and modifying, adjusting the medications is very important with a proper meal plan. Right. Yeah. So we will go on to the next topic. Any questions? I think we will not.
Yeah. Because most of my slides have been discussed already, so that was.
Yeah. Right. If there are no questions,
Sure.
we will move on to the next topic. Dr. Amal?
Yes, ma'am. Now coming to the last presentation of our webinar, this is the topic is post Ramadan follow-up, and it will be given by Dr. Hamid Ashraf sir. Sir is associate professor and ex-director of Rajiv Gandhi Center for Diabetes and Endocrinology, JN Medical College, AMU, Aligarh, and sir has 40 publications in national and international journals. Sir is also editor of Sage and Frontiers publication and a reviewer in BMJ, Frontiers Endocrinology, IGM, and Diabetes Medics. And coming to achievements and awards, Sir is coordinator for Center for Excellence Type 1 Diabetes and founder member of Cancer Consortium, AMU, Aligarh. Over to you, sir.
Yeah, am I audible and visible?
Yes, Hamid.
Yes, yes.
Thank you, the whole team, Saila ma'am and the whole ASI team behind this for giving me this opportunity. Now coming down to the end of very rigorous kind of teaching for last 2 weeks. So coming to the end, that post-Ramzan follow-up, what is the importance? So post-Ramzan assessment, it is the last but very important part of management of diabetes during Ramzan. And I think this is one of the time when we have to listen more to our patient rather than talking, because we are teaching and trying to educate them about all the things, how to manage their fasting and all, and how to manage their medications, how to manage the complications. But this time, I think we need to listen to them how their Ramzan has went, and how many days they were fasting, and how many days they developed complications. So there will be many success and failure stories. So those who are having success, we need to congratulate them that because of your dedication, devotion, and your discipline, you are able to make this month. And there will be so many failure stories also. And they are so dejected that so many patients will tell you, the doctor, this is for the first time in my life that I was not able to fast, and and I don't like it. So at that time, we need to comfort them, and we need to counsel them that it's your basically intentions which matters most if you are talking about the religious part rather than your actions. So we should be very, you can say, compassionate to them that, okay, this time, because of some problems, you might not be able to fast, but next time we will try our best, along with your participation, that the fast should be successful next year. This is the thing which everyone has discussed, but the thing is that in post-Ramzan period, we need to assess whatever the assessment we made prior to Ramzan. We need to look at this, whether that was actually happened with the patient or not, because many patients, when we assess the pre-Ramzan assessment is done, then there are a few categories of the patient. When the patient is low or medium risk and they are ready to fast, so we need to have a look on them in the post-Ramzan period, that this risk category was holding, the patient did not develop any kind of complication and the fasting was safe. But if they develop some complication in that situation, why the complication developed, what was the reason for that, and we need to look at that thing. And in secondary category, we have very high risk patient who are not ready for not observing the fast. They are listening to us and they are very compliant. Okay, you are high risk, you should not fast, and they will tell whatever you are telling, doctor, we will do that. So in that situation, that's not a big issue. But the biggest issue lies here, the third category, where the patient is high risk and they are insisting on fasting. So in that situation, the education, pre-Ramzan education, which we are talking, when to break the fast, how to handle the complications, when to check blood sugars, all these things are very important. So we need to listen their story, how their Ramzan has gone, how they have managed the complication, how many times they have developed symptoms or signs of hyperglycemia or hypoglycemia, or any other kind of complication, and how they have managed, how many times they have to break their fast. So all these things we need to monitor, and we need to keep a record of that, so that's why next time we can do that. And in pre-Ramzan assessment, there are few people who want us that we should tell them that you should not fast, but they are low risk. At that time, we should not be the judge, we should not be the jury. We should tell them that as a practitioner, your score is this, pre-assessment, pre-Ramzan assessment score is this, you can fast. Whether to fast or not, this is your decision. We are not going to do anything for that. So that's also not an issue. So during post-Ramzan follow-up, we need to obtain crucial information about the individual's success and the challenges during Ramzan fasting. And this will ensure the Ramzan fasting and following can be more successful, and the patient can be more confident. And this process should be undertaken before each Ramzan and after each Ramzan, because success of one year does not guarantee success in another year, because diabetes is a progressive disease and things may change, new comorbidities can develop. But still, if a patient has fasted for the whole month in preceding, and then there are high chances that they will make a successful fasting next year. If you are talking about the post-Ramzan follow-up, then definitely followed by 1 month of fasting, there is a intense feasting for 2 to 3 days, and that marks the end of Ramzan. So we should tell our patient that overindulgence should not be there, because moderation is the key. Even in the religious point of view, moderation is celebrated, moderation is liked. So once we are in fasting mode, there the diabetic patient should be told that they should celebrate in moderation, because overindulgence can be dangerous, and if the complications can also happen even after the post Ramzan period. And there are few reports, few studies which have shown that there is increase in the glycemic variability much more than the during the Ramzan period in the post Ramzan period. And we know that glycemic variability can definitely be a problem. So moderation during the feasting is also recommended, and this should be educated during the pre-Ramzan period, and also once we are doing the post-Ramzan assessment, at that time also we should look at it. So these things has already been discussed by Dr. Tejal and Dr. Rakesh Sahay sir. These are, I have, out of so many studies, I have included 2 studies. So this is one of the study which was observational kind of study from Pakistan. Here you can see that, in fact, the weight has, you can say, slightly increased in patients of type 2 diabetes mellitus, and body mass index is also slightly increased, though there was no statistically significant difference, but there was a trend to slightly higher weight after Ramzan. So this tells us that the pre-Ramzan education is very important if you want to have, you can say, benefits, religious benefits as well as medical benefits, and definitely we should be having good amount of pre-Ramzan education. Otherwise, these things is going to happen. Here around 400 patient was there, and here you can see there was no difference in the clinical and anthropometric parameters in these patients. While it was another study from UK where intensive education by the doctor, by the nurses, and by the diabetic educator was given, though sample was quite small. But here you can see almost all the parameters they have improved during Ramzan. This happens because how to proceed during the month of Ramzan. While feasting, the moderation should be there. That is the importance of pre-Ramzan education. And we should assess these kind of things and these parameters after Ramzan to look at what has happened them. If it is better, then we should congratulate the patient, we should motivate the patient. And if the things has not as we are expecting, in that situation we should look at the why the problem has happened. For example, if we have prescribed the patient 1500 or 1600 kilocalorie per day diet, but during Ramzan patient was taking 2000 kilocalorie diet, then definitely weight loss is not going to happen. Even in those patients who have some amount of weight loss or better, some indices like LDL, HDL, and HbA1c, they were better. But in that situation also, it returns to normal within 12 weeks post Ramzan. Even my personal story, in every Ramzan, I lost at least 4 to 5 kgs of weight during first 10 to 15 days. And the moment Ramzan will be over, my mother will be after me that you should eat more, you look weak, and the fasting was, I think, very heavy for you. So within 2-3 weeks, everything will be back to square one. So post Ramadan follow-up, if someone has lost weight, and in that situation, we should try to, specifically if they are obese, in that situation, we should counsel them that you should persist with this weight. For that, you need to put some amount of extra effort that is also required. So, and also the education which you are talking when to breakfast, if you see at this slide, you can see even if the in presence of hypoglycemia and hyperglycemia, many patients did not break their fast. So these things are very important to us, because this time they might have made it, but if they will do same thing next in that situation, patient might not have that good outcome. Patient may have problems, and patient may need hospitalization. So it's very important. And the Dr. Shakti was discussing about artificial intelligence, and these kind of supports can also be provided to the patient to give some amount of idea what to do, when to do, because many patients, even if they are having hyperglycemia, they don't break their fast if they don't have symptoms. In that situation, these things can also be helpful in the future. And another very important thing that we know is smoking is very common in our society, and almost it is a risk factor for everything which we read in our books, not only non-communicable disease, but also for communicable disease like pulmonary tuberculosis. And during the Ramzan fasting period, for a large period of time, patient won't smoke for at least 16 to 18 hours. So in that situation, it can be a good, you can say, it can provide us good ground to counsel our patient that if you can abstain from smoking for 16 hours or 15 hours, in that situation, definitely you can leave it if you want it. And there are some studies where it has shown that faith-based intervention for smoking cessation has been found to be effective. So any kind of you can say addiction in that situation, if the patient is fasting, that provides a good opportunity where we can ask our patient that you can be free from this addiction. Because we know that post-Ramzan changes normal routines when fasting during Ramzan, and the effect of fasting during Ramzan on physical and mental well-being, which will revert to normal once the Ramzan ends. So this provides a good opportunity to assess individual experience. What we are talking day in, day out, that the personalized experience, personalized medicine, and the person-centered care, that could be very, this is the time where we can listen to our patient and we can accordingly, according to the experience of the patient, according to the patient response, according to the patient reports, we can provide a very individualized kind of treatment to our patient. But there has been no direct research on the impact of implementing the lessons learned from the Ramzan, because many patients will lose weight and few patients will gain weight. So how to interpret these data and how to implement that in the total holistic care of the type 2 diabetic patient or diabetic patient is still not available. So here you can see that we start from the pre-Ramzan assessment, and after that, at the end, we come to the post-Ramzan assessment. And the pre-Ramzan education which we give our patient, here you can see that during not only during Ramzan, but also if we have provided good education, then the post-Ramzan period, we can have good glycemic control, better self-monitoring of blood glucose and treatment management. And there is sustained motivation to adhering to the guidance which was given by the doctor. And this leads to greater empowerment to fast safely during next Ramzan. That's all. Thank you very much for your patient listening.
Thank you, Dr. Hamid, for a nice, in the sense, discussing on all the positive and negative aspects of post-Ramadan follow-up, how we should be careful once the patient successful journey, making them again to be eligible for the next Ramadan. Thank you so much. Any questions? I think
I just had a comment.
Yeah.
Actually, as you rightly said, Dr. Nilavani, this post-Ramadan follow-up is actually preparation for the next Ramadan. Because the patient, you are just analyzing what were the difficulties so that they won't be repeated the next time. And because many of them, they have feelings of anxiety and fatigue and all that. So that should also be discussed so that they are ready to face it the next time. So that is normal. And moreover, it's a time for psychosocial change. I mean, the mentality also changes. It's a time for prayers. It's a time for good deeds. So there's a sort of self-cleansing. The people become more communicative, and that social bonding increases. So these are so many different benefits which we should analyze and then, of course, go on, prepare the patient for the next.
I think education plays an important role.
Yeah, very much.
So I think final summary and vote of thanks.
Thank you. Thank you, Hamid sir. Now I would like to call upon Dr. Altamash Sheikh sir. Sir is consultant endocrinologist at Saifi Hospital and Messina Hospital, Mumbai. And sir has various publications in peer-reviewed national and international journals. And sir is speaker at various forums. So to end the discussion, I would like to call upon Altamash sir. Over to you, sir.
Good evening, everybody. I think it's a very, very great program that has been running since across 2 hours or so. I think here I would like to summarize in a way that, yes, the one thing that you need is a Ramzan structured diabetes education. That's one of the foremost pillar that we need to. The way we have our GDM patients, these are receptive patients, Ramzan people or fasting people, any kind of fasting, any religion, any spirituality. These are receptive patients. They are ready to learn, and we should take this as an opportunity to teach to these patients and these people that how they can help beneficially with their own understanding, how it could really be of great importance to them in their control. And Dr. Saktivel did talk about the technology and fasting. We heard about type 1 diabetes, where how the recommendations would change. Of course, you would remember the contraindications better, because these are the people with heart disease or maybe renal disease who require a large doses of insulin, where you would not do. Same thing, how Dr. Suzyani and Dr. Apsia have also talked to us about how you take care about the cardiac and the renal complications in type 2 diabetes. Similarly, other speakers, Dr. Rakesh Sai, Dr. Tejal Lathia, Dr. Hamid Ashraf, talking about the importance, including the fasting importance in daily life across whether Ramzan or non-Ramzan days, how intermittent fasting, and it can help to some people and it cannot help. And most important, the end of Ramzan is not the end of the being receptive phase. The post-Ramzan follow-up is very, very important. The most important thing is to avoid hypoglycemia, hyperglycemia, both, and to give a safe and a efficacious Ramzan. And remember to summarize, more importantly, also that all Ramzan is not the same. Every time it may change by 10 to 11 days, and we need to change the regimen each year, depending upon the season, depending upon the region, and depending upon what is the control at that particular 3 months just before Ramzan. Over to organizers. In the light of lack of time, I have been given a signal. So over to organizers. Thank you so much.
Nice, very nicely since concluded and given a summary of all the speakers, Dr. Altamash. Nice. I think.
Yeah, actually, as I understand, it's finally the patient's choice. I mean, to fast, it's a personal choice. And what we as clinicians can do is just assess the risk, make them aware of it, and if whether it is safe for them, whether it's risky for them, and even if they want to fast against our advice, we should respect that and do the monitoring as is needed, and make them aware that when they should break the fast, or what are the warning signs, or when it would be injurious to their health. So that I think is.
Yeah, I totally agree with you, Dr. Chaudhary. So same thing, risk assessment, and I think education plays an important role, so that they will be very well prepared and to change in the lifestyle, change in the dietary pattern, changes in the medications. All those things are very important. Thank you, Dr. Shahla. Thank you, Dr. Hari. Thank you, ESI, and thank you, Dr. Jabbar, for giving us this opportunity. And it's a pleasure to be amongst all of you. I think I have learned quite a few points while discussing with all the speakers. It was a great learning experience for me as well. Thank you so much.
And thanks to the entire organizing team for having us here today. It was a great pleasure. Thank you.
Right. Nice. Right, Chaudhary.
I think Dr. Sahela was supposed to present the vote of thanks. I think ma'am is not here. So on the behalf of ESI and the whole organizing committee, I would definitely like to thank all the chairpersons and our reporters and our speakers for sparing their valuable time on the weekend and shedding so much light to make the things clear, because it's the education of caregiver is very important. Then only we can have the patient should be in safe hands. For that, education of the educators is very important. So this was a program designed like that only. So thank you, everyone. Thank you, ma'am. Thank you, Dr. Aman.
Thank you, sir. Thank you.
Thank you, everyone.
Okay, ma'am. Bye-bye.
Bye.